make it. But then that was not always. We are passionately working. We always women believe in something more. So now that we are doing it, it's time we acknowledge and get some changes.
We keep receiving your regular updates, and we forward it to everyone, and we wish you great luck
That's
for
kind
your
of you. Yes, thank
candidature.
you. Thank you so much. Thank you.
Here in Vasai, in Palghar district, it's been raining quite heavily. There's no flooding though. And as of now, we are not seeing too many of monsoon illnesses, but soon post-monsoon, we'll be seeing them. Anuradha?
बाळ कसा आहे अंजली?
एकदम फाईन, थँक्यू.
शांत आहे
सध्या तरी.
डॉक्टर ललितचा काहीतरी कम्प्युटरचा प्रॉब्लेम झाला लॅपटॉपचा, तर ते
So can the second speaker start?
We can start.
Yeah, I think Raksha can start, and है ना?
I agree.
Why wait?
Okay, madam. We'll start.
Yeah.
Good afternoon, everyone. I'm Dr. Anuradha Palwankar, Secretary IIP Palghar. I welcome all of you in today's webinar. Gastrointestinal system is very important. It not only helps in digestion and absorption of nutrients, but it also impacts the development of overall development of a child. And today, in this webinar, we are going to discuss diseases of gastrointestinal system in children. And our first speaker is Dr. Raksha Tate madam. Madam has done UG PG in pediatrics from Sion Hospital. She is having 35 years of experience in private practice, and her special interests are childhood constipation, complementary feeding, and parental education. So her today's topic is touching uncovered aspects of childhood constipation. So which is a very common problem nowadays in children, and we are we all are facing the childhood constipation cases in our OPD. So madam is going to talk on childhood constipation. Over to you, madam.
Thank you, Anuradha, for my kind introduction. I can, you'll allow me to share slides? Anuradha?
Yes, madam.
Yeah.
Pallavi, madam. Madam, just wait a minute.
Yeah.
Madam, try now. Hello. Hello. Ma'am, you can try now.
Madam, please share your slides.
Yeah, ma'am. She has a permission. Just try once, ma'am.
Yeah, done. May
But
I
we
start?
are not able to see. Ma'am, we are not able to see your screen.
Now?
Not yet, ma'am.
No, madam.
Not yet.
Okay.
Now we can see, madam.
Yeah. Okay, this is full screen.
Yes.
Am I audible?
Yes, madam.
Yeah. Yeah. Good afternoon, everybody. At the outset, I thank Palghar Academy of Pediatrics to give me an opportunity to express my views on childhood constipation. Before we begin, let us understand that there is lot of literature on childhood constipation with different opinions. So it may happen that views expressed by me here may not match with the references which you have seen, but we will not go into controversies today. As the topic suggests, name reads, touching few uncovered aspects of childhood constipation, I will be just enumerating what are different aspects which are usually not covered in our common CMEs on constipation. And I will try to enumerate on as many aspects as possible. Yeah. First thing is we need to unlearn what we have already learned, but which is now outdated. One is term habitual constipation, which is now outdated. Constipation is not a habit. It's a symptom of, and it is multifactorial problem. So we should no more use term habitual constipation. Now, there was time when we were using lactulose before PEG, that is polyethylene glycol, came into market. And now it is undisputed that PEG is the drug of choice, laxative of choice for childhood constipation for children above 6 months. If any child below 6 months requires laxative, then we should use lactulose, as PEG is not that it cannot be used, but because of its dilution need, it should not be used for children below 6 months. Now, there was concept in the past that change in diet alone without laxative and without toilet training could improve childhood constipation. But there are reports that by the time parents seek medical help for their child's constipation, a long interval elapses between parents seeking medical help and parents noticing that child is constipation. And in developed countries, it is on an average 27 months. So what it implies that usually childhood constipation is for many months before parents come to us. And by that time, there is accumulation of lot of fecal matter in rectum and colon. There could be megacolon, megarectum, and many other complications related to childhood constipation. And that's why almost all cases of childhood constipation require disinfection. But unfortunately, that is not being done by most of us. And this is the reason, one of the reasons why pediatricians all over the world are blamed that we undertreat childhood constipation. Now, question of which guideline to follow comes later, but at least start following some guideline. When I started treating childhood constipation cases, I started following more popular Espagan guideline, but number of cases did not respond to the recommended dose of PEG as per Espagan guideline. So for last almost 6 years, I have been following dose of PEG according to NICE guideline, which is maximum dose of PEG recommended for children up to 5 years is 8 sachets per day and 12 sachets for children up to 12 years for disinfection. Now, What disinfection means? In simple one-line answer, it means removing whatever poo is there in rectum and colon, removing everything. You can compare it with if any property has to be rented. So before that, we vacate our property like that. That there should be no old poo left in colon and rectum, and that is disinfection. Now, those who have seen colonoscopy, now those who know about colonoscopy preparation, similar procedure is done before colonoscopy, that for colon to be visualized, colon should be devoid of any fecal matter, and large dose of polyethylene glycol is given before preparation of colonoscopy. Now, what is the hitch in disinfection? The risk during disinfection in children is there is possibility of exacerbation of symptoms of constipation, or there can be other symptoms when we are doing disinfection. And that is the reason pediatrician must be familiar with those symptoms of exacerbation and should be confident of managing disinfection before they undertake disinfection. A good counseling is must before starting disinfection, and parents would be very anxious during disinfection, and pediatrician or their assistant should be available either online or offline for any difficulty which parents may face during phase of disinfection. Now, is childhood constipation as benign as it was thought earlier? No. If childhood constipation is undertreated or not treated, lot of children may develop enuresis, encopresis, rectal prolapse, anal fissure, bleeding PR. Some may develop dyssynergic defecation, and a large number of children may continue to have constipation into adulthood. And once there is long-term constipation during adulthood, many adults may land up with development of piles, fissure, fistula, rectal prolapse, etc., hernia. And that is the reason we should treat childhood constipation adequately. Now, what all do we need to know about childhood constipation? One is there is no shortcut to long-term constipation. Treatment should start as early as constipation is detected for better outcome. Treatment should be continuous for long term. Disinfection must be followed by maintenance. And dose of laxative has to be titrated as per individual requirement. Even if we have two children of similar age, similar symptoms, similar weight, and both have constipation, and still they both may need different dose of laxative. Now, when we start with treatment of constipation, it should be started with osmotic laxative first, followed by, if required, stimulant laxative is added. Laxative is given in step ladder pattern. It means same dose of laxative is not continued forever. There is waxing and waning of dose. To begin with, we may need gradually stepping up dose for disinfection. And once disinfection is achieved, we start reducing dose and continue with maintenance dose. And that is the reason child is required to come to our OPD for adjusting doses, and frequent visits are more so in first month of treatment. Do not start two laxatives together, and do not stop both laxatives at same time. When child is better and we want to stop treatment, before that, decrease dose of one laxative and then stop, and then do same thing with other laxative. Do not abruptly stop long-term laxative, and they need to be told that laxative should be prepared with proper dilution as per our instruction. But why do we don't do disinfection? Or what is the fear associated with laxative? The first fear is loose motions, which may accompany ingestion of laxative. But is it truly loose motion or it is desired effect of laxative? Then we must understand that when there are frequent watery stools with laxative, it is not actually loose motion. It is not side effect of laxative, but desired effect. And if child is feeling better on laxative is indicated for that child. Risk of dehydration is minimal if laxative is used under supervision and in gradually increasing doses. And parents must be informed that what is expected when we start treatment of constipation is lot of poo is expected, as lot of poo is there in the rectum, and that is the reason we are treating. Constipation is incomplete evacuation. So poo goes on getting accumulated in colon and rectum, and we want it to be removed from intestine, and that is the reason if laxative is effective and it is needed, we would see lot of poo, but still child would not be dehydrated and child will feel better. And this is the assurance given to parents and counseling to be done before we start treatment. Bristol chart, like growth chart. Any pediatrician who is treating childhood constipation must have hard copy of Bristol stool chart in their OPD. Parents can identify what is the type of stool their child is having. We can explain to them that at the end of disinfection, we expect child to be passing type 7 type of stool. And when child is on maintenance therapy, we expect child to pass type 4 or type 5 of stool. And it is very easy for parents to understand when they see the photograph. Now, there are 4 options in treatment. The best option is that child should be treated fully and adequately. But all may not agree for treatment of constipation. And that is the worst thing. Then out of other 2 options, one option is either we do only disinfection without maintenance or start only with maintenance phase without doing disinfection. Then out of these 2, which is better? Doing disinfection without maintenance dose is far better than treating child with maintenance dose of laxative only without doing disinfection, as child would be asymptomatic for far longer period when we do disinfection than only on maintenance phase. When child is put only on maintenance phase, which is done most of the time, majority children, as soon as laxative is stopped, majority children be symptomatic in very short period, as if constipation was never treated. So we must learn how to do disinfection. Now, Journal of Pediatric Gastroenterology and Nutrition, where the original article has been published on Aspirin about evaluation and treatment of childhood constipation guideline. There, if we go to page number 270 and read point number 37 about maintenance phase of laxative, then it reads, maintenance treatment should continue for at least 2 months and all symptoms of constipation should be resolved for at least 1 month before discontinuation of treatment, and treatment should be decreased gradually. This means that we cannot abruptly stop treatment. We need to taper, and tapering ideally should not be done on that dose is given on alternate day, but decreasing dose should be the method of treatment during maintenance and weaning. Now, what it means that all symptoms of constipation should be resolved for at least 1 month before discontinuation of treatment. It means, suppose if child had loss of appetite when child presented with constipation and came for treatment, then child's appetite should improve. But it's not just improve, it should be normal appetite. Parents should not say, okay, now he is eating better than earlier, but still not as much as child should eat. Similar thing about if child had smelly stools, that stool should not be, no more be smelly. The typical smell of feces is fecal odor. It is unpleasant, but not foul smelling. The child who had flatulence or foul flatus should not have flatulence and foul flatus. Abdominal pain should not decrease. It should disappear completely, and child should not complain of abdominal pain once child has been on laxative, disinfection is done, and now on maintenance therapy. Child who was irritable should now be happy child, playful child. And suppose if child had different urinary symptoms, then those also should improve completely. Just passing soft motion every day without straining, but without complete abatement of their existing symptoms is not the goal of treatment of childhood constipation. Or child being better than before is not the goal of treatment of childhood constipation. Now, suppose if pediatrician is in doubt about diagnosis of constipation, or if parents are not convinced about diagnosis of constipation, in that case, we may do X-ray abdomen, though diagnosis of idiopathic chronic childhood constipation does not require any investigation. It is by history and examination. But if at all, if we need any investigation, then X-ray abdomen is preferred over abdominal sonography. However, before sending patient for X-ray, we should tell them that if X-ray abdomen shows positive findings about constipation, we may be able to say that it is favoring diagnosis of constipation, but negative X-ray finding does not rule out constipation. Now, many times it happens that when we ask history of different symptoms related to constipation about frequency, type of stool or anything, number of parents tell us that no, my child is not constipated, child passes stools every day, child passes type 4 or type 5 stool every day. But still we feel that somehow whole scene looks like child is constipated. In that case, we should take help of past history. As most of us don't do disinfection. So even if child has been partially treated for childhood constipation in the past, child would surely not improve permanently and child would again have recurrence of symptoms of constipation. And that's where past history of constipation plays very good role in diagnosing present constipation if present symptoms are not very convincing about constipation. And this is given in NICE guideline. We need to read all guidelines very minutely, very carefully, and we need to read in between lines to pick up these points. And that is the reason it is not exaggerated. It is no exaggeration to say that once constipation is always constipation if child is untreated or undertreated, and there are lots of cases where they relapse because they again go back to their old habits of food and holding behavior. Now, to make things little interesting, I'm sharing 5 cases of childhood constipation. Number of cases are related to medical people from doctor family and a nurse. First case is about Emma, 20 months old daughter of a nurse working at pediatric nursing home, had recurrent loose motions. She was thrice admitted in a nursing home where she was working. This is about a decade ago. And at that time, my knowledge about childhood constipation was not even in infancy. And once, after a lot of counseling of both the parents, Emma was given an enema for excessive crying due to severe abdominal pain with bloating, and she had not passed stools for 2 days. And look at that. What a sight it was after enema. She passed large number of small black and brown balls of very hard stools, type 1 of Bristol stool type. These balls made sound when fell on ground. They could be counted, and those balls were so dry that they could be picked up from floor without leaving any stain on floor. And actually, in true sense, her bottom did not need any cleaning at all. That was the scene after enema. But what happened after that? After going home, she passed very large foul motion again in an hour, but it was combination of pellets with mucoid feces. Seeing such large motion in such a short time, they came back to fight with me for giving enema, as they feared that there will be probability of needing hospitalization again for gastroenteritis. And this was in spite of child who had responded. She had stopped crying, her abdominal pain had disappeared markedly, and she was playful now. And still, parents were apprehensive. This was my beginning of understanding what is in true sense spurious diarrhea, what is fecal impaction, parental perceptions, and need for repeated counseling, be it effective or ineffective. And in retrospect, I felt Emma was most likely a case of spurious diarrhea secondary to severe constipation. Diarrhea secondary to constipation is known as spurious diarrhea, and it is also known as paradoxical diarrhea or overflow diarrhea. Now, what we need to remember is all spurious diarrhea cases have fecal impaction, but all fecal impactions do not have spurious diarrhea. Next case is a case of 8-year-old boy who came for frequency of urine. He was a chubby, very talkative boy brought by equally chubby parents for frequency of urine, which had lasted for 3 to 4 weeks and which ranged from 20 to 30 times or more per day, but it was without pain, without weakness, without polyuria, without polyphagia. They had come with 42 pages of various reports to rule out renal as well as endocrine causes and infections. And essentially, all the reports were normal. It was surely not a case of polyuria also. And after history taking, child was given enema. After giving enema, he occupied washroom for nearly 45 minutes. But at the end of 45 minutes, he came out happily, as if relieved. But he was screaming embarrassingly that whole commode was filled with his stools. We need to remember that frequency of urine is not necessarily related only to urine infections or diabetes. Constipation can also lead to frequency of urine and many other urinary symptoms. Third case is of retention of urine in a boy 3 years old. Once I got a frantic call at 10 p.m. for this boy who happens to be son of a radiologist. He had retention of urine, but his sonography was normal. And everything was done as advised by another pediatrician whom they had consulted. Child was already given lot of fluids. They had already given hot fomentation, sitz bath and everything, but nothing had worked. Child did not have phimosis and bladder was full. Boy's howling in pain was making our telephonic conversation difficult. After a lot of convincing, parent agreed to give him enema. and see which worked like a magic wand of Harry Potter. And ever since then, from that center, many X-ray abdomen and some abdominal sonographies are reported as child is constipated, rather than earlier reporting, which number of times used to say just gaseous distension of abdomen or lot of gases and stool, which suggest either subacute intestinal obstruction, or they would say, or rule out obstruction, which is no more that frequent. Now, this is a case of grandchild of a family physician and son of a dentist, who is now 6 years old. And I have seen this boy when he was 21 months. He was constipated, but parents were unwilling to follow my method of treatment and my doses of treatment for constipation. On his 5th birthday, I asked grandfather about his status of constipation, and he confidently said, now no constipation. But as I have said earlier, that if child is undertreated, once constipation is always constipation. I did not want to accept my defeat. So to cut long story short, I asked just one question to grandfather and I got the answer that he defecates standing. I understood that child is severely constipated. But what about grandfather and what about family? The dentist told father that my friend's 6.5-year-old son also defecates standing. What is the big deal in how any child defecates? And this reply and such comments are not shocking. If we pediatricians do not understand what happens because of child defecating standing, how do we expect common people to understand? This boy was on suboptimal dose of PEG and that also intermittently, which made him pass small amount of soft foul mucoid stool 5 times a day, but in standing position, but without straining. What it means? Child is improved, child is cured of constipation? No. Partial treatment changes symptomatology of constipation to such an extent that at times, when such children come to our OPD, their presenting symptoms could be misleading and it may mislead parents as well as to us. Why would this child pass stools 4 to 5 times a day? Is it normal? Why stool should be foul? Why stool should be mucoid? And why would he pass small amount repeatedly rather than passing stools at one time, once or twice in a day? Now, this same family physician once forwarded sonography report of 7-year-old girl with UTI. And he grumblingly said, look at this report. I am referring this girl for abdominal sonography and what sonologist reports is constipation on USG. He was not aware of the causal relationship between UTI and constipation and more so in girls. And I explained to him. And to add to this sonologist was none other than parent of 3-year-old boy with retention of urine. Now, what do we understand from these cases? Constipation presents with various different symptoms, not necessarily just decreased frequency or straining or hardness. There are so many different presentations and symptomatology. So we must be familiar with different symptoms. Counseling at times may not be effective, but we should not be frustrated. I understand it takes so much time that if we start seeing patients of constipation the way we should and spend that much time for counseling and treatment, we may not be able to complete our other OPD and other patients may go away. But we can always find out some other solution, train our assistants and counsel. Now, there are different sentences given in Rome 4 criteria, different terminologies. But then, is it complete? Passage of infrequent stools is constipation is very clear to everybody and nobody needs convincing for that. But if any child who is older than 6 months comes to our OPD and says that child passes frequent motions more than 3 times a day, then what do we understand? Majority of the time, we say it is likely to be gastrocolic reflux. But are all these cases really in true sense gastrocolic reflux, or many of them must be having constipation, and that is the reason they pass small frequent stools more than 3 to 4 times a day? Now, recurrent diarrhea, as in case of Emma, who was admitted number of times for acute gastroenteritis, are all cases of diarrhea are secondary to lactose intolerance, or they are only infection and that is the reason they are getting recurrent diarrhea, or because of their bottle feeding they keep on getting infected and again develop diarrhea? Or large number of such cases could be spurious diarrhea, which are actually constipation but they are presenting as diarrhea. Detailed history taking is necessary to arrive at diagnosis of spurious diarrhea and differentiate between infective diarrhea and spurious diarrhea. Now, when parents say that my child's stools are mucoid, we think only of dysentery, but number of such cases are because of constipation and they don't need antibiotic, they need laxative. Now, for majority of pediatricians and almost all the parents, they feel that child develops retentive posture is for passing motion rather than not passing motion, and child is training to pass motion. There are many different retentive postures, but most commonly they say that child goes on toes or crosses legs and takes support of sofa or something, and they see that child is training. But we must understand that this posture is for not passing motion rather than passing. Child doesn't want to undergo painful experience at defecation, and that is the reason holds on to stools. But at the end of it, child has to pass motion someday or other, and which child passes, but most of the time it is incomplete evacuation. Now, if child has already developed retentive posture, then can we really manage childhood constipation without correcting retentive posture? No. Child's this behavior really takes long time to change once we start treatment for laxative, but we need to follow that child has been able to overcome this behavior or no. And this impaction is really needed for all such kids with retentive posture. Now, there is another sentence in the guideline: 2 or fewer defecation in the toilet per week in a child of developmental age of at least 4 years. It means any child who is more than 4 years should be completely toilet trained, and that child should pass motion in toilet and not anywhere in the house and not on newspaper or plastic sheet. Now, do we ask the such question to any parent of child who is more than 4 years that where does he pass motion? This is a point to be remembered, and number of families who have common washroom which is outside home, such children pass stools at home but somewhere in the house, and they are made to sit on some newspaper and plastic paper, which is really shocking that they don't use washroom even at this age. And most of them are constipated. Now, at number of CMEs on constipation, we hear that if any child takes very long time in washroom, it is indicative of child being constipated. Parents may say that child is taking long time in washroom to play with water, but that is not true that we understand. But in case if parents say that my child comes out of washroom too quickly, do we pay any attention? Does literature pay any attention? If child comes out of washroom too quickly, in that case, child will get constipated even if child is not constipated at present. But more or less, child comes out of washroom quickly because child gets pain while passing stools, and that is the reason child comes out quickly. We need to teach child to remain in washroom for adequate time until there is complete evacuation. Now, we pediatricians see number of cases of autism spectrum disorder, ADHD, hypothyroidism, children on long-term anti-epileptic drugs, mentally retarded children, children with mental retardation with or without CP, urinary tract infection, or many other urinary symptoms which are associated with constipation in large percentage of cases. Such parents should be primed that their child is prone to develop constipation anytime in future if they are not constipated when child is first time presented to us. And we must remember that treatment is same, be it idiopathic constipation or organic constipation. And children with organic constipation or ASD, hypothyroidism, or any other cases, they do require treatment for their primary disease. But at the same time, if they are constipated, their treatment is on similar line like idiopathic constipation, disinfection followed by maintenance therapy. Now, though abdominal pain is not considered a symptom of or constipation by guideline, or it is not evaluated, is not added in the guideline because it is subjective and there are lots of other causes of for abdominal pain. But suppose we know that this particular child has come for abdominal pain and this is secondary to constipation. In that case, should we give antispasmodic to this child? Should we give antacid considering that child might be having gastritis or PPI? No. These children need paracetamol rather than antispasmodic, as most of the antispasmodics are associated with constipation, which is one of their side effects. Same with antacids and same with PPI. Similar thing about vomiting. If vomiting is because of constipation, in that case, we need to empty their bowel rather than give antiemetic. And if at all, if we are giving antiemetic, then domperidone has lesser constipation than ondansetron. There is still time. I can go ahead or wind up.
Madam, please wind up.
Yeah. Okay. I hope this presentation has been of help to at least few people. And thanks a lot again to Palghar Academy of Pediatrics and all the people for attending this session. Thank you.
Thank you, madam, for detailed discussion of constipation in children. Now I request our next speaker, Dr. Lalit Verma, sir.
Raksha, it was excellent.
Thank
Yeah,
you.
you want me to give some comments?
Yes, I think so. We have 10
Yeah, that
minutes
is
now.
for him. Yeah. So I first want to say that I always thought constipation is something which people understand and yet don't understand. But anyway, I must compliment that you did an amazingly wonderful job. So well said, Raksha ji, that I was very impressed, and that you spoke right from your heart se bhi niche lever se.
Thanks a lot, madam.
And
Means a lot to
very
me.
well said. Only one point which I want to add, because you gave no opportunity, is such a wonderful messages were extremely clear, is that I wanted to use the word what is refractory constipation. So, if you may allow, should I just tell that?
Yes, yes, sure, madam.
Okay, thank you, Raksha ji. So basically, what Raksha was saying is that using the right doses, she talked to us about impaction. She talked to us about the various presentations, of constipation. She talked to us about the various misunderstanding where people can't understand the position, the training, everything she dealt very well. But what I want to say is, despite using the right doses, if there is not adequate response that you would have expected in that child, and you're not able to achieve your goal, then you should think of refractory constipation, because refractory constipation is a definition which says despite adequate doses, no satisfactory response for 3 months. And in that case, one of the first studies that were done was from our department, which we are presenting, on 1,300 children with constipation, where our data was close to only 22% or so of refractory constipation, but the data says up to 300 in different centers if abroad can be refractive. That is where you need to rule out dyssynergia. That is where is the role where sometimes understanding the role of an anal manometry, role of biofeedback gets very important. So nowadays that when we started our practice, our bread and butters, we used to be pain abdomen and constipation. But thanks to the massive teaching that happened in this country, with that teaching as well as IP and all those modules, the pediatricians have got pretty empowered to treat it. So the only the parts that come to us are these parts refractive, where we end up doing the manometry and the biofeedbacks and the response that the people see. What do I mean? So when you go to pass a stool, the anal sphincter should open. That's in your control. If it opens, the rectum contracts and this opens. So this is automatic. But because of the constipation, either they don't open or rather close it, or the rectum doesn't contract. So we identify these problems and we train them and we do it. And it's very good response that I'm seeing. And it'll take me, a couple of years to give the data of the long term, but the preliminary data we've released. So that was all I just wanted to add. And as she talked about autism and all, so there is a time where a gastroenterologist, since we are not doing all this constipation pain, it's all going to the pediatricians. So we need to do, we do, like I started the first in India called the Autism Gut Clinic, where we are talking about not only constipation, the allergies, the dysbiosis, and other problems that you deal with it. Just once a week, we do on Tuesday. Not that I have great patience, just I announced it only on the autism day. But we do a lot of neurogastroenterology work. So there are some motility disorders which can be in constipation. So after what Raksha said, you are stuck, then please do think about us. We do exist, whether in person, online, you all can connect where we can further guide, because all of us, our main goal is to keep you can't see all this million children, so we need to divide. So while all that is with the pediatrician, let the motility disorders, the refractory cases, the dyssynergia cases need to be sorted out by us.
Thank you, madam.
Thank you, madam.
Thank you for your guidance. And let me introduce first, madam. Madam is pediatric gastroenterologist. She's senior director of Department of Pediatric Gastroenterology, Hepatology, Liver Transplantation, Medanta, the Medicity, Gurgaon, Delhi. She is awarded with BC Roy National Award by Honorable President of India for her pioneering work in liver transplant in India, and she has distinguished teacher awarded by IMA National Board of Exam. She's eminent doctor personality awarded by IMA, and in Forbes magazine 2021 as powerful performer. Madam has established first uh, department in country of pediatric gastroenterology, hepatology, and liver transplant, and started her first fellowship in Ph.D. program in India. And she has more than 1,000 presentations in international and national publications and more than 50 chapters in books. She was president of Indian Society of Gastroenterology, Hepatology, and Nutrition, ISPAGAN, in 2022 and 2023. So we got such a multifaceted expert today. I welcome Madam and thank you for your guidance on constipation.
Thank you, Anuradha. Raksha, hats off. I'm going to invite you as a speaker soon.
Thanks a lot, madam. Great. It means a lot, really.
I will. No, I'm going to invite you soon. Thank you. Thank you.
So Nandini, we got such a great expert. Now we'll go ahead with our further talk. Our next speaker, Dr. Lalit Verma. He has done MD Pediatric and Super Specialization Gastroenterology, Fellow of American Academy of Pediatrics, USA, Fellowship in Pediatric Gastroenterology, Hepatology, and Nutrition from University of Alberta, Canada. He has 15 years of experience in his field. His fields of experience are pediatric liver transplant, jaundice, and liver cirrhosis. His areas of interest are pediatric liver transplant, liver diseases, various GI and pancreatic disorders. Dr. Lalit has created a benchmark by performing 4,500 pediatric endoscopies and procedures for GI and liver diseases in children. So his topic is chronic diarrheal diseases in children, case-based approach. So I request Dr. Lalit Verma sir to go ahead with the topic.
Hi, very good evening actually. Dr. Neelam, very welcome. So nice to see you, but I probably you guys can see me or you can't.
Can't see you.
Hear you?
I know that, just like last time, some goof up. I'm actually in the hospital and, it took time with a lot of winds. I think they were trying to fix. But yeah, you can hear me. I can see you actually. Something
can
wrong
hear
No,
with
but
the
your video, can you do on?
video, Dr. Neelam. I can't. I did try. It's
Okay,
actually
fair
on,
enough.
but there's something, yeah.
Fair enough. Fair enough.
But Dr.
Wanted to
Dr. Akshay,
admire
really
you.
impressed. Yeah, Dr. Neelam, we missed you. I think in the Lit Fest, you came on Sunday, probably with the flight scheduling and with your multiple trips. And
I was there on Sunday. I missed you.
yes, yes,
But
yes.
we'll see you in the national conference.
Yes, and Dr. Neelam is also the organizing chairman for this year's ISPEGAN. And of course, we look forward for the IP presidency also. Dr. Akshay, wonderful talk as usual. It was good. It was good to hear.
Thanks a lot,
So,
Lalit.
So today's topic is approach to infant and toddler with diarrhea. Actually, it's a very vast topic. I've tried to cover it. Let's see what we can deal with. And it has to be two-way discussion, not just one. So you can see my screen.
Yes,
Yeah.
sir.
Yeah. So, by definition, passage of three or more loose stools or watery stools in 24 hours is considered as diarrhea. It should take the shape of the container. So, like the pot wherever the child is stooling. Now, it can be recent change in consistency or the character of stool. Now, what we mean by chronic diarrhea is it has to be incidence in onset, but lasting for more than 4 weeks. But some may, practitioners will take it as 2 weeks or more as chronic diarrhea. The difference between persistent and chronic is not really much, but chronic diarrhea can resolve. Persistent diarrhea is something which needs like a good workup. It has to last for more than 2 weeks and further on. Now, there's something called intractable diarrhea of infancy, which usually starts in less than 3 months of age. It's very severe. It needs parenteral nutrition and it has a very high mortality. Can anyone unmute and give me some kind of differentials for intractable diarrhea? Anyone?
Malabsorption,
Due to?
fat malabsorption,
Okay. So
lactose intolerance.
yeah. So I mean something. So something like microvillus inclusion disease, something like channelopathies. So they start very early in the life, just after birth. They require hospital admissions, IV parental nutrition, and once the child is home, like in India. So we had a lot of kids actually in Canada, but in India it's really impossible to have them over a long period of time. So usually you see channelopathies in Saudi Arabian kids. There's something called tufting disorder. So all this requires, like, the stooling pattern is really horrific. 8 to 10 stools per day, dehydration, parental nutrition, and so on. So some of these examples are there. Now, how do you approach a case of diarrhea? So, basically, is it a chronic diarrhea? Nor do you differentiate between a small bowel versus a large bowel diarrhea, or it can be a mixed picture. Then the third one is like whether it's osmotic, secretory, or mixed. Now, as Dr. Anjali said, whether it's maldigestion or malabsorption. And then, have to look into associated features like anemia, weight loss, rash, and other systemic involvement like arthritis and so on in older kids. Now, when you have to differentiate between malabsorption and maldigestion is like when you look into the stool fats, it's more in maldigestion. Fatty acid crystals are present more so in malabsorption. Of course, with malabsorption, they will have a lot of flatulence, bloating, which is not there in maldigestion. Anemia is associated with malabsorption. You'll also have hypoproteinemia in malabsorption. And if you look into the stool volume, it's really a big stool volume in malabsorption compared to the maldigestion. Now, how do you compare small bowel versus large bowel? I think Dr. Neelam had shared one of the leaflets which me or Dr. Anjali had shared in the group. So basically, small bowel diarrheas, the stool volume is large versus the large bowel, the volume is small. The reason is, there is a lot of water absorption in the even in the distal part of small intestine, as well as the initial part of large intestine. That's the reason in large bowel diarrhea, the volumes will be small. When you see a blood in stool, mostly it is large bowel diarrhea, but not necessarily. Sometimes there can be rush of blood from the small gut also, but most of the times it's large gut. Then rectal symptoms are more common, like tenesmus in large bowel diarrheas. You see steatorias, greasy stools is definitely small bowel. Carbohydrate malabsorption is small bowel. Protein malabsorption is small bowel. Pain, when you compare small bowel, it is more in the periumbilical area. And when you have to compare that with large bowel, it's mostly in the hypogastric or the left lower quadrant. And it usually gets better after the passage of stool. The color of the stool in small bowel diarrhea is pale versus large bowel diarrhea, which has normal stooling pattern. Nutrition deficiency is very common in small bowel diarrheas, not as common as in large bowel unless there is associated blood in stool like ulcerative colitis or Crohn's. Now, the other main differential is between the osmotic and the secretory diarrhea. So, perineal redness is present in osmotic. The stool volume in osmotic is less than 200 ml per 24 hours versus secretory is more than 200. There's a lot of purging, watery stools, explosions, and a lot of gases in osmotic because it collects a lot of pressure, mainly with carbohydrates. There's a lot of pressure and a lot of explosions. Versus secretory, which is like it won't explode. There's minimal gas, but it is watery. Now, if you have to respond to a fasting, of course, diarrhea with osmotic diarrhea will stop once you are fasting. But in secretory, the diarrhea will continue. The sodium in osmotic is less than 70 milliequivalents versus secretory it's more than 70. Reducing substance is present in osmotic because it's mostly carbohydrate related. Stool pH is less than 5.5 in osmotic versus 5.5, more than 5.5 in secretory. And the osmotic gap, of course, will be more in osmotic. Now, what other questions will you ask? So, you have to ask all these very reasonable questions. Is there any relation with change in the diet? Is there any associated blood and fever? Is the child bottle feeding? Is there any weight loss? The types of milk, whether it's formula versus breast, and the types of preparation. Is there any addition of sugar because it can be osmotic because of the osmolality because of sugars? If you're giving ORS, is it adequately prepared? Previous history of diarrhea and stooling pattern. Now, is there a recent history of antibiotic use? So that can be antibiotic associated diarrhea. History of travel, of course, if you go to an endemic area, hepatitis A, there can be Shigella, Salmonella, and so on. Infections in other family members. So basically, a history of travel or food together. Always ask about allergies, eczema, cow's milk protein allergy or any other food allergies will have something in the family member. Always, chart growth charts and growth pattern. Always jot that down and make sure they're following the pattern. Is there any other multivitamin deficiency, sparse hair or something? Vitamin A and D deficiency signs, if they are there, like in the form of rickets, vision, and other things in older kids. Always ask about the immunization history, especially with the rota, and if there is a BCG scar or not. Now, some of the common reasons in infants, toddlers, and older children. So let's look into infants first. So infants with persistent diarrhea, that I said, tufting disorder, microvillus inclusion disease. Then there's something called post-enteritis syndrome, which can happen with one episode of infection. Other common reason is cow's milk protein allergy. Always look into primary immunodeficiency, whether it's CVID or other immunodeficiency. Autoimmune enteropathy is rare, but it is definitely there. Congenital lymphangiectasias again is difficult, but can be picked up with the blood test and the endoscopy. Now, when you go into toddlers age group, then of course look into celiac, giardiasis, tuberculosis, immunodeficiency, food protein allergy. Rarely celiac disease will go into toddlers, but there can be less than 1% chance. Intestinal lymphangiectasias, toddlers diarrhea is very common. Protracted diarrhea and A beta lipoproteinemia. When you go into older child, it's irritable bowel syndrome. Inflammatory bowel disease is common, celiac disease, tuberculosis, not much. Tuberculosis will cause diarrhea, tropical screw, and again immunodeficiency. Now, stepwise diagnostic workup. So always look into first thing is microbiology, send stools for parasites, cultures, rotavirus, electrolytes, and if required, biofire. Always differentiate between the secretory and osmotic by sending the stool for both of them. Sorry. Now, these are some of the non-invasive tests which can be done before we dig deeper, like going into endoscopies and so on. So, if you're concerned about celiac, do send a TTG. Also include a DGP if the child is less than 2 years, and of course, we're dealing with infants, so deaminated gliadin protein is important. Send a steatocrit, look for fat malabsorption. Fecal reducing substance, which is usually absent but can be present in carbohydrate malabsorption. Elastase is present in the stool mostly in pancreas disorder. Chymotrypsin will be present in pancreas disorder. Fecal ocal blood is usually blood loss due to cow's milk protein allergy or inflammatory bowel disease or due to surgical causes. Fecal calprotectin actually is a surrogate marker for any kind of inflammation. So even if the child has infection, it will come positive. The usual values are less than 50, but the concern values are more than 200 microgram per gram of stool. So it is seen in IBD, a lot of infections, but mostly we use it for inflammatory bowel disease. Leukocytes again is a sign of colonic inflammation. Alpha-1 antitrypsin, anyone can unmute and tell me what is it signifies? Anyone for alpha-1 antitrypsin in stool, not otherwise. Yes, Dr. Anjali, I think you're unmuted.
But I don't know the answer.
Okay, so it's protein losing enteropathy, where we usually send the alpha-1 antitrypsin to have a diagnosis in place. Breath hydrogen test is usually done for carbohydrate malabsorption and small intestinal bowel overgrowth, mostly after a major surgery like NEC. Immunodeficiency work, of course, try and do primary and secondary workup. So then the further testing is like, sending, looking to blood in stool, whether there is increased calprotectin, if there is pain in abdomen. Some of the other tests that we can do is like, send HME staining, do an endoscopy, imaging wise, you can do an USG, CT scan, and MRCP mode to look into the pancreas. So I'll skip this because it's there in the next further talk. Okay. So case one. So based on this slide, we'll just come up with some differential that will help us. So 9 months old male, lose stools for more than 2 months, stool frequency around 5 to 6 per day, nighttime symptoms present in the form of stooling, abdominal distension, greasy stool, malodorous stool is definitely there, not gaining weight and height, occasionally mild cough. On exam, pallor is there, irritable, thin-billed child, no edema, stomatitis is present, dry skin, no hepatosplenomegaly, but the abdominal distension in the form of gaseousness. Rest is not signified. Any differentials from anyone?
A beta lipoproteinemia because there's greasy stool, so fat
Okay.
malabsorption.
Okay, good. Anything? The child is 9 months old. Symptoms are there, of course, say like after 7, 8 months. Okay, I'll give more.
Yes.
Yeah, please go ahead.
Celiac disease.
Okay, you got it. So, CBC, of course, the hemoglobin was on the lower side. The child was pale, platelets were fine. TTGIJ is definitely high. Now, when we say high means it need not be 200. Anything above the values given by the lab is okay. Sometimes they have 8, sometimes they have 10, but anything beyond 20 is definitely significant. And in a child less than 2 years, anyone can admit, we had discussed this earlier, what other tests to be sent?
GGT.
DGP, perfect. Deaminated
DGP.
gliadin protein, because sometimes the TTGIG won't be positive. Yeah. So, had partial improvement, diarrhea persisted, weight and height no improvement, but then we put the child on gluten-free diet and significant improvement was seen. I'm just keeping the cases short, otherwise we'll run over time. The second one, so that was celiac disease, perfect. Diagnosis was done, TTG was positive, and the child is on gluten-free diet and doing well. The second one is 8-month-old female with blood in stool for past 2 months, intermittent initially but later persistent. Bowel movements were 3 to 5 per day, 50% had blood. Birth weight 2.7, but the present weight was okay at 7.5. No vomiting, no fever, otherwise active child. On exam, pallor was there, no rashes, abdomen was soft, no distension, rectal, no fissure, but there was a diaper rash. Anyone with the differential?
Megaloblastic.
So 8-month-old child, symptoms with blood in stools, almost like 50% of the times for 2 months. In between, it got better for some time, but then again started having persistent blood. Yeah, please differential.
Megaloblastic anemia.
Anemia, okay. Anyone?
Milk protein allergy.
Good. Anyone? Any other one? Hemoglobin had dropped to 8.7. ESR was
Meckles.
high. Stool culture was no growth. Other differentials? What should be the next step?
Colonoscopy.
Okay, so my differential were infections, CMPA, food allergies, because the child had started on the weaning diet, whether it's polyps. So the earliest polyp I figured out was 7-month-old child, so I kept that in mind. Because there was just subtle signs of growth was okay. So considering CMPA, as I thought, as somebody said, I also started this child on amino acid based formula. She responded for roughly 2 weeks, but then again started having blood in stools, sometimes 10 ml, sometimes 20 ml of stools every day. Scopy was planned, and since the signs and symptoms persisted. So this was my endoscopy findings, just way back. So you see all this aphthous ulcers. Anybody now? So look at my impression. Apart from allergy, consider very early onset inflammatory bowel disease. So stool fecal calprotectin, I had to hide this, but that was more than 1500. Polyp was not seen. And of course, this was the histopathology report by a very good histopathologist, Dr. Anjali. So it said ill-formed granuloma and moderate colitis. Anyone now? So this is very early onset inflammatory bowel disease. So we know that it is not as common, but we are picking up more cases. Even in the Indian population, whether it's India or abroad, it's basically caused by a genetic defect that affects the immune system or disturbs the epithelial barrier. It is collectively known as monogenic IBD. IBD is in the form of intestinal inflammation before the age of 6 years, and also known as early onset IBD, even higher in those presenting during infancy. So usually young onset, yeah, we take it as younger than 6 years. Family history of IBD can be there, but there can be other immunodeficiency in the family. They can present with recurrent infections or unexplained fever, or just like this child, just with blood in stool. Other features like arthritis, PSC, anemia, endocrine dysfunctions can be there. Very severe form are usually resistant to conventional therapy. Sometimes they have required bone marrow transplants as well. Lesions of the skin, nails, or hair are common. Now, very difficult to diagnose, but we usually send a whole exome. Whole genome sequencing is playing an important role with the identification of novel genetic mutations. Immunosuppressants have to be used, and sometimes, as I said, bone marrow transplant is attempted. So this is for this child. She was heterozygous for LRBA, which is common variable immunodeficiency, CVID with autoimmunity. She's almost 6 years. I recently saw her. She was on infliximab, but just last 2 times I've switched her to adalimumab, which is subcutaneous and easy because they come from Pune. She's doing very well. She at 6 years, she's 19 kg, well-grown child. Usually, I tell them to do the workup like every 3 months, so that because they stay in Pune, and the plan is to do an endoscopy to just make sure that things are all right. So always check the vaccine status. Try and avoid live vaccines because they're on immunosuppression. That was about that case. Anything anyone wants to know about that case?
Will she have to take infliximab all her life?
No, so all this while so I started on infliximab. Then after 1 year, I tried changing it to something like Azuran, which did not, because parents were concerned that they cannot come to Mumbai every time, and they only wanted to get it done in Mumbai, Mira. So then we tried steroids plus Azuran, did not work because most of these monogenic IBDs do not respond well. So she was on infliximab till like early this year. For the last 2 times, she's been on adalimumab, which is subcutaneous injection, so easier. She's doing okay. So I told them that she might do well even on adalimumab. We don't know yet, so we'll have to see. Okay.
Thank you.
No problem. So, Dr. Anjali, I think this was one of your patients. So, let's see if you remember. So, 5 weeks old infant with 3 episodes of apneic spells, no significant birth event, born full term, breast and top fat, birth weight 2.8 kg, current weight 3 kg, chest X-ray was done, 2D echo, APG, all within normal range. Is there anything else you want to know?
Birth history was normal. Okay.
Okay. So she was with IVF. I think they still follow with you, Dr. Anjali. They stay in the same. So
Okay.
IVF was born in one of the South Bombay hospitals. Very significant apneic spells, and we were actually worried. So we actually thought whether it's heart or it's something else. Anybody has a differential in mind?
Cystic fibrosis.
Okay, good. Fine. I'll do the next case also. So the second case is 2-month-old infant with visible specks of blood, multiple loose stools, 6 to 7 per day, with mucus for the past 6 weeks since, like, So formula fed was admitted for IV hydration in Rajasthan. USG was done, which was normal. No fever. Stool culture was sent, which was E. coli. Treated with antibiotics, which was in the form of parenteral and oral both. Blood test was done. Hemoglobin was slightly, like, it's a physiological nodule, so we'll accept 10.5. INR was okay. No improvement. So I think I saw them at Dr. Bharwat's clinic here. Right. So later was admitted in Mira. So what happened? I'll tell you about this patient. Patient was in Rajasthan, so they were in Jodhpur. One of the doctors must have said the key formula fed क्यों दे रहे breast milk क्यों नहीं दे रहे. So there was no breast milk enough. So they were had to be formula fed. Now again he got dehydrated. So was given IV hydration, stayed in the IPICU over there for 5 days. They were not happy, so they came back to Mumbai. Now any differentials in both the cases are almost the similar ones. I'm not given much, but yeah, purposely. So in this case, the 5-week-old infant had multiple loose stools as well, 6 to 8 in a day.
Bottle filling.
Okay, I'll give more. So stools of the first child, 4 to 5 per day, semi-form. The significant reflux, micro aspirations where they're vomiting 3 to 4 episodes per day. 50% of the feeds were actually thrown out. This was the first case. Anybody now? So the reason was microaspiration, cyanotic spells. We actually got worried whether it's heart, right? So I switched the formula to amino acid based formula, and this was of course cow's milk protein allergy. Child responded. Mother was asked to avoid dairy or eggs if she wanted to breastfeed. Symptoms had resolved on the following to visit. The child right now, I think Simran is the name. Very beautiful girl, and I saw her just few months back. So both these cases are cow's milk protein allergy. I just wanted to bring up that CMPA can present in a difficult scenario also like this. They can become dehydrated, will require ICU admission. The second child actually was slightly mismanaged. The doctor said, do not switch to soy formula and continue the same formula. But of course, they required soy. And in fact, I had to switch that child to hydrolyzed formula. So CMP can induce a diverse range of symptoms with variable intensity. It can be immediate. So if you see here, early signs, minutes to 2 hours with the first feeds, mostly it is IgE mediated. The delayed onset is usually 48 hours to 1 week later. Now, this can be IgE mediated or it can be non-IgE mediated both. So 15 to 21% of children with CMP can have GERD, and they have an overlap definitely like the first child. So had CMP a significant GERD, microaspiration leading to pneumonia, cyanotic spells, and so on. Diagnosis, what dietary advice should we give? Stop cow's milk based formula, yes. Switch to hydrolyzed formula. If the mother is breastfeeding, always encourage that. Continue breastfeeding, add calcium supplements for the mother, and wean with dairy-free diet. Now, CMP can also present with significant colic pain. Most of the times it's around 10% overlap. Now, indications for hydrolyzed formulas are faltering weight and poor weight gain, severe vomiting like in the first child, intractable atopy, reactive airway disease, not responding to routine therapy. So there's something called Hainer's disease, Hainer's syndrome, which is actually one of the extra intestinal manifestation of cow's milk protein allergy as well. Colic, if it is significant, then you'll have to switch from a soy-based formula, whatever formula, to hydrolyzed formula if the child is not breastfeeding. And if the child has significant diarrhea plus minus blood, then you switch the child to hydrolyzed formula. You can obviously, like later on, if it is non-affording patient, you can wean it to a soy-based formula once the child is okay. Now, there are two ways to diagnose this. The CMP is thorough medical history and physical exam. But if CMP is suspected, specific tests can be performed to aid diagnosis. But although we can do IgE-based, skin prick, serum-based IgE test, usually in a younger child less than 1 year, it is not advisable. So the gold standard is to do a food challenge elimination diet, which helps in diagnosis of both IgE-mediated and non-IgE. So basically, take out the food and the child does well, then it's called elimination diet. Now, so this is basically the same thing as CMP is suspected. An infant must avoid cow's milk protein for a duration of 2 to 4 weeks for IgE-mediated symptoms and up to 6 weeks for non-IgE-mediated symptoms. If improvement is seen, you can re-challenge with cow's milk after 1 to 3 months and see. If symptoms reoccur, confirm the diagnosis. But with a caution that this has to be done in a clinic setting or a hospital setting, because some of these reactions are really alarming. So do not try and do it at home. If elimination of CMP does not improve symptoms, CMP is very highly unlikely. So basically, you require 2 weeks to make sure or diagnose your child with CMP. So basically, oral food challenge is a drop of formula is put on the lips. If no reaction occurs after 15 minutes, the child is given orally and the dose is increased from 0.5 to 1 to 3 ml to 30 ml to 50 ml to 100 ml every 30 minutes. Child should receive at least 250 ml of cow's milk based formula each day for the next week, and the parents told to observe the child for rate reactions. So this is basically done in a Western kind of setting. I have done it once or twice here, but it is very taxing. So let's not get there. Now, usually what we confuse is cow's milk protein allergy versus lactose intolerance. We always see lactose intolerant. But what actually is lactose intolerance? So lactose is one of the most important carbohydrates which is present in breast milk and milk-based formulas and provide many benefits to the babies. So let's not take it right away unless we are very sure. So CMP is actually allergic to protein. Lactose intolerance is unable to digest lactose, which is a carbohydrate, due to a deficiency of enzyme called lactase. Now CMP is immune mediated. Lactose is not immune mediated. CMP is most common food allergy in infant. There are only rare cases of congenital lactose intolerance which are seen in the Scandinavian countries. India has very rare population. Of course, since there's a lot of mixing, you can find a couple of cases here and there, but very rare. Yes, secondary lactose intolerance is very common, which can happen mostly after viral infection like rota infection. And usually it will last for 2 weeks. So in that time, try and take the lactose out, put them on a soy-based formula if the child is formula bred. Now, this is one of the data from India. So, children 164 kids with chronic diarrhea in less than 3 years. So, if you see, CMPA has 39% even way back in 2009. And celiac disease, of course, had 48%. The rare ones were IBD, but I think IBD will go up now in this decade. Giardiasis is there, and then non-specific we don't find a reason. So composition of human milk versus cow, the red ones are the ones which actually cause the cow's milk protein allergy. So if you see, it is very negligible or not present in human milk. That's the reason if the mother is breastfeeding, very rare chances, less than 0.3% chances, or for the baby to have cow's milk protein allergy. But it is, yes, definitely there. So that's the reason we ask mothers to go off dairy if she wants to continue breastfeeding. In cow's milk protein allergy, if somebody is taking cow's milk based formula, of course you have to take away the cow's milk, because the culprit is alpha 1 casein and beta casein, which causes the harm. This is one of the very other interesting case. Actually, I only wanted to present this once when I spoke to Dr. Anuradha at the New Bombay meeting. But yes, it got like, diagram influence, which is good in a way. So very interesting case. I want everybody's attention here. So a 5.5-month-old exclusively breastfed infant brought to the clinic with chief complaints of diarrhea from the past 4 months. Passage of 4 to 5 loose, bulky, smelly, non-bloody stools. Weight around 4.5 kgs at present. Height 59 centimeter, cranky, irritable, mild abdominal tenderness, bowel sounds present, yes. On the lab investigation, stool reducing substance was positive, stool fats were around more than 15%, and stool pH was less than 5. Any differential?
Lactose intolerance.
Okay.
Congestion.
And
Primary or secondary?
again, secondary perhaps.
Okay. Good.
Yeah, but perhaps
It's
some
possible.
viral diarrhea. Yeah.
Yeah. Yeah. Anything
And
else?
that 5.5 months. So such a small child.
Hmm.
Exclusively breast. Again, CMPA, like you said.
Okay. It can present late also, yes. Yeah.
Stool fat is more than 15%, so like we said.
Right. So it can be a sign of just malabsorption or maldigestion, right? So
Yeah.
maldigestion can be just because of some acute infection, and they have fats, TGs or something. Okay, fine. So this is actually challenging. I had to involve Shruti as well. So, stool for fat. So basically, this is like one of the tests that we do. It can be qualitative and quantitative both. So basically, the best one is to do quantitative. It's the gold standard. However, we can't differentiate between pancreatic and intestinal causes of fat malabsorption. So basically, steatorrhea is if 15% fat output in less than 6 months of age, or more than 7% in a child who is more than 6 months. Limited use in practical due to issues of collecting, processing, the labs availability, and whether they are able to run the lab properly, like they do the test properly or not. So this was very interesting. Both the kids had the same thing. So if you look here, so I had to send a whole exome after convincing the parents that this is not something simple. So both the kids had lactase persistence, lactase disorder, and they also had pancreatic lipase deficiency. So both the things are there, lactase and lipase both. The second sibling, who actually had picked up earlier, the one that I presented, of course, we knew then it's pancreatic lipase deficiency. So both the kids, so I just messaged mother for this report because I had shared it to Shruti as well. And both the kids have the same thing. Now the younger one, this kid that is in front of you is getting oily stools. So I have cut down on the fat. They both are on. What should we put them on if it's pancreatic lipase deficiency? Anyone? They need to be on pancreatic enzymes. So they are on panlipase or Creon, whichever is available in the area. So with that, they are doing extremely well. They belong to Parsi family. Excellent weight, height, and everything is fine. But they party a lot. Sobo guys, Sobo family. So then they're like, "Arey, last night we went, we had a pizza with cheese and this and that kind of stuff." So, but both the kids are motamoti doing fine. So diarrhea again. It can lead to morbidity and mortality. Last few slides. Basically, it's a vicious cycle of diarrhea, malnutrition. So, so once the kid has diarrhea, will have malabsorption, which will cause inadequate dietary intake, which will cause further weight loss, growth faltering, lower immunity, more infection, and this cycle goes on and on. Now, there are various things that we can do. So, if the dehydration is present, which is severe persistent diarrhea, no dehydration present in persistent diarrhea, and if there's blood in stool, which is dysentery. So, if it is dysentery, of course, we'll use antimicrobial recommended for Shigella and a salmonella if you pick one, and always treat the dehydration with ORS and give zinc. If it is persistent diarrhea, give multivitamin and minerals and also add probiotic. If it is severe persistent diarrhea, then of course we need to see in a hospital-based setup. So golden rules are: if the child is breastfeeding, exclusive breastfeeding for 6 months, continue breastfeeding, energy dense complementary food for older infants, low osmolarity ORS, which is we have been following that, and zinc supplementation. Now, nutritional therapy in diarrhea. So, if the child has acute diarrhea in the form of infection, continue breastfeeding. If the child is formula fed, make sure that the mother is using adequate amount of the formula powder and the water, and it's in a clean. Make sure that they're not using bottle. Even for an older child, the diarrhea can go haywire and they can get dehydrated. If the child has persistent and chronic diarrhea, which can be seen in infants, toddlers, it can be IBD and IBS. Make sure the nutrition with proteins and fats and it's well covered. Um, there are certain conditions like short gut and intestinal lymphangiectasias where you need to be putting them on special diet like MCT based diet. I do come across a lot of kids with short gut, mostly post surgery with NECE or volvulus or malrotation, and sometimes it's difficult. I always tell the families that it will take time, but it will get better. I put them on, simpler diets, MCT based diet, and do a cycling probiotics 1 week on, 1 week off for certain duration. Food allergies and intolerance. Again, we know that it's not just cow's milk. India is on a kind of allergic march, so we are coming across a lot of food allergies. Some of the kids that I've seen here in the clinic as well, somebody is allergic to kiwi, somebody is allergic to chickpeas. So make sure we are not missing on those. Now, drug therapy can be in the form of antibiotic if you actually know the stool is growing this bug and that is a culprit. In very young infants, usually E. coli is present even in a non-pathogenic form. So make sure it's not the real infection and you do not over-treat with antibiotic. Of course, probiotics are helpful and it's evolving in the last decade. Anti-motility drugs and anti-secretory drugs used with a caution and real caution. Absorbents can be used. Immune suppression in IBD in the form of infliximab or azathioprine, methotrexate, and promotion of cell growth with zinc growth hormone if required. Now, impact of high lactose diet during diarrhea. So basically, cow's milk or regular lactose will cause secondary lactose post-infection. There is secondary lactose intolerance because of the lactase deficiency. So basically, if you go from left to right, infections will cause diarrhea, will damage the intestinal lining, will cause lower levels of lactase, and that's the reason for lactose intolerance. So basically, the food will be undigested because of the unabsorbed lactose, and there will be increased secretion, more diarrhea, more peristalsis. So make sure in that particular time frame, you put the child on lactose-free diet, and if the child is on formula, a soy formula can be used. Now, yeah, the signature symptom for a prolonged and explosive watery diarrhea is proliferation of intestinal bacteria, malodorous stool. It attracts large molecules of water, leading to water retention and high osmotic load. And then definitely with all this, there will be nutrition deficiency, and basically the transit time is accelerated. That's why you find undigested food products in this scenario. So basically, when you use a lactose-free versus lactose diet, treatment failure rates are lesser in lactose-free diet. Stool frequency is lower in lactose-free diet, and duration of diarrhea significant lowers in lactose-free diet. And we have all noticed this, and we all come across this. The other supplements that can be used in somebody who has chronic diarrhea is supplementation with vitamin A, because it causes proliferation of the cellular mucosal cells and differentiation of immune cells. Vitamin E and C and selenium are act as antioxidants, and then we of course add zinc in most of the times. It improves water and electrolyte absorption, modulates host resistance to infectious agents, and repairs the GI gut cells. So this is just in nutshell, for chronic diarrhea, an algorithm. So if weight and height is normal, check the nutrition status. If it's normal, stools, no fat. Then chronic non-specific diarrhea, which is again common, you see in toddlers diarrhea in older kids. Excessive intake of fruit juices, then just ask them to avoid fruit juices completely, artificial ones at least. Excessive intake of carbonated fluids, then of course we have to bring it down. If the fat intake is low, increase fat to 35 to 40% as required. Now, if the diarrhea related to carbohydrate intake is there, then basically it's carbohydrate malabsorption. Rule out lactose intolerance, whether it's secondary or primary. If no improvement, then put them on lactose-free diet. If it is sucrose, then decrease sucrose in the diet, add saccharosydase. If no improvement, then sucrose-free diet can be attempted. If weight loss is there, stool shows fats, there's definite malabsorption, need to take bigger, need to do endoscopy and specific treatment, send workup for celiac, fecal elasticity required, alpha 1 antitrypsin phospholipid required. That was about chronic diarrheas in infancy. Sorry, there were more things, but I think we are all time restricted. So I tried to do my best. Anyways, yeah,
Thank you, Dr. Lalit, for such a nice presentation. I want to ask you one question. We have one baby, full-term severe diarrhea. Birth weight was 900 grams, and we started with EBM. Baby initially tolerated, but later on started with loose motions.
Okay.
Loose motions were frequent, and intermittent vomiting was there. But we continued, and then there was weight loss also. We did stool test. pH was acidic, and reducing substances were present. So
Okay.
we took opinion of Dr. Samir Sheikh sir also.
Yeah.
Sir, we initially we shifted to lactose-free formula. Baby started gaining weight, but again there was weight loss. So we took opinion of Sheikh sir. Sir said you continue with breast milk, stop lactose-free formula. It must be viral diarrhea. But again, baby developed loose motions after starting mother's milk, and baby is not gaining weight. Baby is losing 1-2 gram weight daily. So, and baby's day of life is 26 now. Baby is tolerating 18 ml feed. Intermittent vomiting is there, but still baby is not gaining weight. So, how we should proceed?
So baby is 27 days, you said, right? If I'm not wrong. 27 days and 900 grams.
Now baby is 1 kg. Initially gained weight, but now baby is not gaining weight and having
Losing weight
loose
instead.
motions on mother's milk.
Okay. Is the mother of dairy?
Pardon?
Is the mother of dairy herself? Like mother is breastfeeding, right? EPM.
Yeah.
But
So
has the
I don't have that history, sir. I have to ask.
Acha. So I think there can be two things. So first thing is like some of these preterm babies may require more time, but I agree that 1 to 2 grams weight loss instead of gaining weight, especially in the preemie conditions, never that reinforcing. So one thing is of course send stool for cultures. Send ask mother to stop her dairy completely. Ask her to so even in preterms also some of the other forms of allergies can exist. It's just difficult because they are preemie, so we say कि नहीं होगा, but it is possible. The other conditions probably are not there, like those difficult concerns of chronic diarrhea should not be there, and also have a stool chart, like how many stool, if there is a volume, if they can weigh and see if it is less than 10 grams, it's okay per kg, right? So basically more than 10 gram per kg is significant. So let's have that history, and then of course let's look into intake and output chart, whether getting adequate calories. You said 18 ml, probably in a 1 kg. Let's see if we can make it like concentrated. But mother has to go off dairy, and if she can go off nuts, eggs is what I usually do for initially,
Okay,
and a
sir.
stool culture.
Stool culture. Okay,
Yeah.
sir. Thank you.
And then, of course, last time we discussed, right, in preemies, probiotics are like, plus and minuses. So usually I say no because we don't know how it's going to act. So let's avoid that part. Yeah.
Okay,
Yeah.
sir. Thank you, sir. I request Dr. Neelam Mohan madam to give her expert opinion.
Thank you, Lalit. That was very interesting. I enjoyed all the cases that you were projecting and all that. Couple of things, and I'm very grateful. You're truly humble to share that I shared those pamphlets. Yes, I wanted everybody to understand the importance of maldigestion, malabsorption, celiac. So I came out with a lot of educational flyers I wonder whether you all had an opportunity, all of you. You do see, because it's not possible if we don't do every day. Some things we don't remember, and even me, sometimes like catch-up immunization, I need to just see and ask my junior what is that. So it's like all of us don't know everything about everything. So we
Right.
need to have these things handy. And the case which he
Can I
presented,
just a minute,
reflux.
Lalit, can you please stop share?
Yeah, yeah.
Thank you.
Yeah, so the case which he was showing about the reflux, obviously, immediately I made out it is going to be reflux for apnea. And we've had a lot of instances, and we want to convey this message that if you get a baby who is suffering from apnea in a few months of age, in the first few months of age, then just before you think about all the time, three things we keep thinking, whether it is anemia, breath holding spell, or whether it's an abnormal seizure. Besides that, also think about reflux, because reflux doesn't mean always vomiting. That's what I want to say. And it gets very difficult to understand whether CMPI gives rise to reflux or it was reflux alone. So I'm not going to debate that with Lalit in this forum, whether treating reflux itself was okay. So that part, I think we'll leave it. But for you all to understand, even with experts, we are not sure whether CMPI and reflux go hand in hand. Are they? So was it a pure? So that thing. But yes, do think about reflux and look into those positions. But having said that, we don't want you all to overtreat every patient with a PPI and every patient with reflux medication. Taking opinion on any case is always useful, because the guideline is that above infancy, you can give a trial of therapy for 3 weeks to see the response in a child. But in infancy, you have to earn the diagnosis. You just can't empirically start because you're thinking, because this is called an atypical presentation if we thought of reflux. So in atypical presentation, it's always better to get your diagnosis a little bit sure. And sometimes in India, it gets very difficult how to treat. For example, I had the opportunity of just looking at Nadaji's grandchild. And now, being a health minister, now obviously he's going to go to six pediatricians. I mean that doctor shopping one and things like that. So it gets very embarrassing. All of us don't have uniformity in talking, and we think disagreeing with the other person is going to make you feel great. I think it actually ends up making you more, like we are insulting each other, and that should not be done. We need to understand if somebody knows more about it in that subject and humbly put it across, yeah, yeah, something like that. It gets very difficult. So this was a typical, there was blood in the stool. Now, blood in the stool, one person will think infection, the other person will straight away think CMPI. I'll be a person who will, if it is my child, neither will I give antibiotic, neither will I change the milk. So I would want to know what it is. But the other person might say, why is she wasting her money trying to know what it is? Because I have a scope like you have a stethoscope. So my scope is say 5 millimeter. So I would just like to put it in the rectum, literally in an OPD basis without sedation, to see if I can find any lesions. But if the patient comes to you, you will think, oh, half mad, she wants to do a sigmoid. So the guidelines that are made are not meant one sheet for all. You're just like trying to help and do it. But you have to individualize to a person and a patient. There may be somebody who can't afford a hydrolyzed milk. There may be a patient who can't. So shy away from antibiotics in the initial period, even if you need to spend your money on diagnosing the condition, my thought. But of course, I cannot say this to a government. People, they may not agree with me that you want to spend on a test. So that's why I said individualize, because I make the national guidelines for everything, but the same guidelines I may not follow every time.
True. Anyone else with? So I think pretty much, I think people got that. I would only like to add that those last two siblings in the family were pretty interesting because again that
I think the
lipase and
connection went weak. So all that I just wanted to say is we are all family. We need to understand, respect each other's capability. We need to take opinion from each other. What we would do for our children, we always pick up a phone and talk to a colleague and do. So we should do the same thing. And obviously, as Gandhiji said, each patient is your client is your god. So we need to just give the right thing. That's all I have to say. And all of us can't have the same drop of ocean. We have different drops. We need to respect each other. We need to take opinion when in doubt.
Thank you, madam.
perfect.
And guidelines are just to make things easy, but don't copy that and say, oh, this is said or this is said. It gets very embarrassing because one person writes DMSA, the other person doesn't want to do, the other person says, do this. It gets very difficult. So if somebody's treating and anybody comes to you for a second opinion, say he's good, he's doing the right thing. Good, just follow up. That makes you actually reach a better height. And as you grow, I think that's what maturity I've learned. Maybe I was not like this when I was 30 years old, but probably I think that's what I've learned, how to respect others and just understand everybody is doing the right thing.
अनुराधा मॅडम हेमंत सरांना काही बोलायचंय?
अनुराधा, माझं नाव
Over to Hemant.
हा बोला सर.
माझं नाव प्रोग्राम मध्ये कशासाठी टाकलाय? टाकलाय ना?
हो सर, स्पीकर कोड साठी.
मग बोलू मी आता?
हो सर.
नीलम मॅडम, फॉर युअर इन्फॉर्मेशन, Marathi is official language of IIP Maharashtra. We are disconnected with this country because we talk foreign language.
No, I love the way you write about
I
India.
hope you get elected, and then
No,
you.
but I want you to send me a book on Maharashtra. That's a gift for me, a
Okay.
Maharashtrian language, and I promise I'll learn all the language. And I promise you that.
Fine. I hope you get elected, and then you ensure that all Indian languages, as they are given in Constitution, become official languages of IIP. Only then we can reach masses. We are a foreign body.
You
Nobody on
always
the
say
street
that.
knows IIP. And we do not know
I
nobody.
agree.
We are foreign bodies. Okay, fine. So
You'll be the advisor, definitely.
I'm going to talk in Marathi.
Yes.
I just told you this.
Yes.
आता एकदम उत्तर ध्रुव आणि दक्षिण ध्रुव हे सगळे फार उंच उंच बोलले. मी तुम्हाला जमिनीवरच सांगणार आहे. आणि हे अंजली, अनुराधा या हुशार लोकांसाठी मनोरंजन आहे. हे तुमच्यासाठी नाही आहे. साध्या डॉक्टरला जुलाब, डिसेंट्री आणि डायरियातलाच फरक कळत नाही. पाण्यासारखे जुलाब झाले म्हणजे डिसेंट्री नाही, डायरिया म्हणजे पाण्यासारखे जुलाब. ते व्हायरसमुळे होतात. आणि रक्त पडते, पोट दुखते, आव पडते म्हणजे डिसेंट्री. त्याला अँटीबायोटिक किंवा औषध लागते. पातळ पाणी होते ते स्मॉल इंटेस्टिनच्या आजारामुळे होते. आणि रक्त पडते, आव पडते ती लार्ज इंटेस्टिन पडते. तुमच्या डोळ्याला रक्त दिसलं तरच अँटीबायोटिक लिहा. मायक्रोस्कोप आला, ऑकल्ट ब्लड लिहितो, 2-4 रेड सेल लिहितो, त्याचा रिपोर्ट. पाण्यासारख्या जुलाबाला संडास तपासाचा खर्च करू नका. त्रास वाढवू नका तुमचा आणि त्याचा. त्याला परत तुमच्याकडे यायला लागतं, रिक्षाचे पैसे द्यायला लागतात, तुमचे फी द्यायला लागते, आणि त्याने काही फायदा होत नाही. तुम्ही जर अँटीबायोटिक दिला तर बरे व्हायला 8-10 दिवस लागतात, आणि नाही दिलं तर 3 दिवसांनी बरा होतो, 3.5 दिवसांनी बरा होतो. असं मी 2 लाख मुलं पाहिल्यावर सांगत आहे. सो मला सिरियसली घ्या. तुमच्या गट्स ठेवा, हिंमत ठेवा अँटीबायोटिक न देण्याची. तुम्ही दिल्यामुळे यू विल डू हार्म, आणि आपण शपथ घेतली आहे की वी विल नॉट डू हार्म. तुम्ही बॅक्टेरियल डायरिया डायग्नोज केल्याशिवाय अँटीबायोटिक देऊ नका. हे झालं नंबर 1. मग मी तुम्हाला पाकिस्तानची ट्रायल सांगत आहे. मी जरा गोष्टी सांगणार आहे. पहिली गोष्ट, आपल्याला धड शिकवलेलं नाही याची आहे. आम्ही आपले थातूर मातूर कसे तरी नापास नाही केलं म्हणून पास होऊन MBBS होऊन जातो. तर चांगलं शिका, रोज शिका, सारखं शिका, आणि सगळ्यांना सांगा, कारण सांगताना पक्क होतं. नंबर 1. नंबर 2, पाकिस्तानमध्ये त्यांनी ट्रायल काय केली की साबणाने हात धुतले आणि वॅक्सिन दिलं. 2 अलग अलग गावांमध्ये काही ठिकाणी रोटा व्हायरस दिली, काही ठिकाणी साबणाने हात धुतले, आणि दोघांनी सारखाच डायरिया कमी झाला. म्हणजे व्हायरसचा वॅक्सिन तर द्यायलाच पाहिजे, मग ते फक्त रोटा व्हायरस थांबवते. पण साबणाने म्हणजे हात जर धुतले तर सगळेच आजार कमी होतात, सगळे डायरिया कमी होतात, आणि बर्म्स होत नाहीत. वम्स झालं तर वर्मा सरांकडे औषधाला जायला लागते. वम्स होऊ नका देऊ, बाहेर खाऊ नका. नंबर 3. मग वर्मा सरांची स्लाइड केवढी छान होती. त्याने ललित सर आहे क्या आपकी गए?
सर आहेत सर.
नाही, कुठे? आय कॅन्ट सी हिम. ललित,
Yes, yes, I can.
यू आर अराउंड. आई एम सो प्राउड ऑफ यू. आपने कितनी भाषा में धन्यवाद लिखा?
That is what you like the most. Okay.
नहीं,
great.
थोड़ा आपका पेन लेके उसमें हिंदी में भी लिख दीजिएगा. तो
हिंदी होगा सर, उसमें हिंदी होना
सर
चाहिए.
मैंने रिसर्च किया पूरे स्लाइड पे. 2 घंटा आपकी स्लाइड सिस्टर, वो हमारी पल्लवी मैडम यूट्यूब देख रही थी, तो उन्होंने आपकी
अच्छा.
स्लाइड ऑफ नहीं करी, तो मुझे पूरे देखने का मौका मिला. अगले बार लिख दीजिए ना, हिंदी पे दया कर लीजिए. आपने वो फॉरेन की
Definitely.
स्लाइड कॉपी की है, उसमें हिंदी नहीं है. कर लो.
नहीं नहीं, पक्का पक्का
सर, आई एम प्राउड ऑफ यू. यू आर द ओनली पर्सन आफ्टर मी हु पुट्स मेनी लैंग्वेज स्लाइड्स. आई एम ग्रेटफुल टू
सर,
यू.
ये है ना, इधर एक बंगाली में आई कैन सी, हिंदी
अरे
का
सर पढ़ लो ना आप. मैंने पूरा पढ़ा हूँ, आपने नहीं पढ़ा है.
गुड गुड.
आई विश यू
डाल
गुड.
देंगे
आई एम
सर
प्राउड ऑफ
नेक्स्ट
यू
टाइम.
पहला. हाँ, और हम लोग अभी लाइव मीटिंग है ना, मेरे यहाँ खाने का मीटिंग फिर चालू करेंगे, तो आपके दर्शन हो जाएंगे. ये
श्योर सर, श्योर.
स्क्रीन में देख के मजा नहीं आता है.
डेफिनेटली.
ठीक है. देन आई टोल्ड यू पाकिस्तान ट्रायल. देन आई टेल यू दैट ट्रीटमेंट ऑफ डायरिया इज पानी पानी पानी. सुकुमार, सु यानी अच्छा, सुसु यानी पानी, सु यानी अच्छा, सुसु यानी पेशाब. तो बच्चों को सुकुमार बनाओ, सुसु घटा तो गड़बड़. तो मैं आपको अभी स्लाइड्स बता के एक कहानी बताने वाला हूँ. Can you see the slides? By any
Yes,
chance?
sir. Yes, sir.
Yes, you can
Yes,
see
sir.
it.
It is full screen also.
So ये
Yes,
बच्चे की याची गोष्ट अशी आहे की याला एक छोट्या वाटीवर पाण्यामध्ये फुल ओआरएसचं पॅकेट टाकून 4-5 पाकिटं पाजले आणि याला कन्व्हल्शन झाले सोडियम जास्त झाल्यामुळे. त्यामुळे बरोबर शिकवणं खूप महत्वाचं आहे. नाही तर घरचं पातळ पाणी पाजलं ना, घरचं सरबत पाणी, साधं पाणी, आपण खूपच जास्त मीठ आणि साखर खातो. पाणी पिलं तरी बरं आहे, तर पाणी तरी द्यायला पाहिजे, पण ओआरएसच्या चुका करू नका. मग एका खेड्यामध्ये खूप मुलं होते, खूप उंदीर होते. सगळ्यांना जुलाब लागले. उंदरांनी इकडे तिकडे गेले, पाणी मिळालं, पिलं, बरे झाले. यांचं पाणी ओट्यावर ठेवलं होतं म्हणून हे खराब झाले. तर पाणी जमिनीवर ठेवा. तुमच्या घरात पोराला पाणी मागायला लागत असेल तर दुष्काळ आहे, तुमच्या घरी उपासमार आहे, म्हणून 10 पैकी 9 मुलं खराब आहेत. जमिनीवर कोपऱ्यात खाऊ ठेवा, आपले मुलं छान होऊन जातील. उंदरांना मायबाप लागत नाही पाणी द्यायला, अन्न द्यायला, आपले मुलांना लागत नाही, खाली ठेवून द्या. हे मी कसं सांगायचं हे सांगत आहे. ही हवेची बाहुली आहे, हवा भरून फुगली आहे. यातला जर हवा कमी झाली तर ही खराब होते. आपण पाणी भरलेले फुगे आहे. जुलाबात पाणी गेलं, घामात पाणी गेलं, उलटीत पाणी गेलं, किंवा प्यायला कमी मिळालं, किंवा आजारात पाणी पित नाही, तर आपण खराब होतो. तर सू चांगली होईल एवढं पाणी पाहिलं. ओआरएस आयुर्वेदाची देणगी आहे. आयुर्वेदात सांगितलं आहे की जुलाबाच्या माणसाला नारळाचं पाणी द्या, भाताचं पाणी द्या, गाजराचं पेय म्हणजे त्याला आपण सूप म्हणतो, पातळ अन्न द्या. आणि नव्या युगामध्ये या आता नवीन 1957 मध्ये डॉक्टर हेमेंद्रनाथ चटर्जी यांनी कलकत्त्याला असं पेय देऊन कॉलराचे पेशंट्स वाचवले पहिल्यांदा. त्यांनी ओआरएस ला जन्म दिला. आणि हे जे ग्रे सूट मध्ये आहेत हे दिलीप महालनोबिस, आम्ही यांचा कलकत्ता IIP मेडिकॉनला सत्कार करून घेतला स्पेशल यांचा, कारण यांनी ओआरएस बनवलं. यांना जगातले सगळे मेडिसिनचे अवॉर्ड्स मिळालेले आहेत. ते कसे मिळाले याची गोष्ट सांगतो की 1971 मध्ये 1 लाख बांगलादेशी निर्वासित आपल्याकडे होते आणि कॉलराची साथ सुरू झाली. 4000 एका कॉलनीमध्ये 4000 लोकांना कॉलरा झाला आणि पूर्ण वेस्ट बेंगॉलमध्ये जेवढं सलाईन होतं ते पहिल्या दिवशी संपलं. कॉलरा असा आजार आहे की आयव्ही लावलं तरी 30% डेथ रेट असतो. मग यांनी काय केलं, त्यांनी भाताचं पाणी केलं आणि 4000 लोकांना द्यायला स्टाफच नाही, तर नातेवाईकांनी बादली भरून भरून भाताचं पाणी त्यात मीठ टाकलेलं हे पाजलं आणि या सगळ्यांना वाचवलं. 1% मॉर्टॅलिटी होती त्यांची, 90% लोक वाचले. आणि त्यातून मग पुढे अभ्यास होऊन इलेक्ट्रोलाइटचा अभ्यास होऊन ओआरएसचा जन्म झाला आणि त्यांना सगळे अवॉर्ड्स मिळाले. आम्ही ओआरएस म्हणतो ना, काही कळत नाही, कोणी घेत नाही. त्याची चव आवडत नाही, त्याचा वास आवडत नाही, नापास व्हायचं असलं की ORS द्यायला पाहिजे. नाहीतर भाताचं पाणी द्या, डाळीचं पाणी द्या, तो पितो ते द्या ना, तो जे काय पितो ते द्या. आणि त्याला गंगाजल भरा. ORS नाही कळत, गंगाजल कळते. गंगाजल का म्हणा, तर एकदा सागर राजाला 1000 मुलं होते, ते मरत होते आजाराने, तर भगीरथाने गंगा आणली. आणि आपल्याकडे कोणी मरायला टेकले की गंगाजल नेतात, पाचतात. मी गंगोत्रीला जाऊन 10 लिटर आणलेलं आहे, कोणाला पाहिजे माझ्याकडनं घेऊन जा, पेशंटना बरं वाटलं, मज्जा. तर सोपं आहे ना, लोकांना कळते आपल्या की गंगाजलाने बरे होतात. तर ना बाळ छान छान मुतील एवढं गंगाजल पाहिजे, असं म्हटलं की बाळ बरं होणार. आणि हे सगळ्यात छान, जुलाबाशी कट्टी करायची, रोटा वॅक्सिन द्या. सगळ्या आजाराची कट्टी करायची तर सगळी वॅक्सिन द्या. हे झालं जुलाबाबद्दल. आता मी कॉन्स्टिपेशनची एक कविता म्हणणार आहे, तुम्हाला मजा येईल. पप्पू टट्टी नाही करता, पप्पू चाय पिता. हे प्रत्येक मुलाची, आपल्या भारतात जन्मला ना तर त्याला हा आजार होणारच. हा जन्मसिद्ध त्याचा आजार आहे. भारतात जन्मल्याचं पाप किंवा पुण्य त्यांनी केलं त्याला हे होतच. कारण आम्ही मायबाप त्यांना चहा पाजतो, त्यांना दूध पाजतो, चहा वरणाचं पाणी पाजतो, डाळीचं पाणी पाजतो. ते खूप मुततात, रात्री उठतात कारण उपाशी असतात, आणि त्यांना पांढरे होतात कारण त्यांना ॲनिमिया होऊन जातो, आणि कारण गाईच्या दुधाने आयर्न कमी होऊन जातं, आणि त्यांना संडासला खडा होतो, त्यांना कॉन्स्टिपेशन होते. हा राष्ट्रीय आजार आहे भारताचा. मुलांचा राष्ट्रीय नंबर आजार कॉन्स्टिपेशन आहे. ते माझं पॅशन आहे, ते दूर करणे. आणि उपासमार हे त्याचं कारण आहे. त्याला डॉक्टर करून फायदा नाही. त्याला शिरा, डाळ, भात, चणे, कुरमुरे आणि खाऊचा कोपरा पाहिजे. कोणाच प्राण्याला आजार होत नाही. माझ्याकडे फक्त आदिवासींच्या मुलांना हा आजार नाही झाला. हिंदूंना झाला, मुसलमानांना झाला, ख्रिश्चनांना झाला, कोळ्यांना झाला, फक्त आदिवासींना नाही झाला, कारण त्यांच्याकडे गाई म्हशीच नाहीत. आणि त्यांची मुलं तर तुम्ही हे आपण शिकूया. ते मी हिंदीमध्येच केलंय, मराठीत पण केलंय, इंग्लिशमध्ये पण आहे, पण तुम्हाला मी हिंदी सांगतोय. पप्पू टट्टी नाही करता. तुम्हाला वाचता येईल का बघा. आय डोंट नो इफ आय कॅन मेक इट बिग. येईल. हे शेअर झालंय काय?
नाही, स्लाइड नाही चेंज झालाय.
स्लाइड नाही चेंज झालं ना, परत करा. आता दिसतं का? आला ना, आता आला का?
येस सर.
आला. हा, आता इज दॅट इनफ? यू कॅन सी, आय होप. पप्पू टट्टी नहीं करता. पप्पू म्हणजे बाळ. बेबी टट्टी नहीं करता, बेबी चाय पीता है, बेबी दूध पीता है, बेबी जूस पीता है, बेबी पेशाब करता है, पर टट्टी नहीं करता. बच्चा सफेद दिखता है, बच्चा दुबला हुआ है, बच्चा रात को रोता है, पर टट्टी नहीं करता. ना पूछे क्यों, कोई हमें कब्जियत क्यों हुआ, चाय दूध पिला दिया तो कब्जियत हो गया. पर अब जमाना बदल गया है. मतलब चम्मच में खाने, बच्चे का खाना चम्मच में लो, उसको टेढ़ा करो, अगर गिरा तो उसमें पानी ज्यादा है, उससे भूखा रहेगा, कब्जियत होगा. गाढ़ा अनाज खाओ जो आप खाते हो. चूहा का बच्चा, शेर का बच्चा माँ के साथ खाता है जो माँ खा रही है. आप वही खाइए जो बच्चे को खिलाएंगे, और आप जो खाते हो खिलाइए. तो अभी बेबी सब खाता है, दाल चावल खाता है, सब्जी खाता है, फल खाता है, फ्रूट खाता है, अच्छी टट्टी करता है. जय हो पप्पू. मुझे सिर्फ छोटे बच्चे को पप्पू कहना है, डोंट टेक मी इन एनी अदर स्पिरिट. इसको हम अंग्रेजी में भी बोलते हैं. देयर इज ए nursery rhyme called as call the doctor just now. So this is based on that. Baby says, I drank milk, I drank juice, I drank liquid food just now. Stomach paining, stomach paining, stomach paining just now. They get stomach pain, they can't pass motions. Call the doctor, call the doctor, call the doctor just now. Constipation, constipation, constipation just now. Stop liquid feeds, stop cow milk, stop juice kanji just now. Start home food, start solid food just now. No constipation, no constipation, no constipation just now. हे का हेच माहिती असायला पाहिजे, आणि हे आईला आई व्हायच्या आधी माहिती व्हायला पाहिजे. तिला बाळांपणात बर्थडेला पहिल्या दिवशी हा कागद द्या, कारण ती पाजणारच त्याला, तिची आजी, तिची सासू, ते सगळे त्याला पाजणारच पातळ अन्न, आणि त्याला कॉन्स्टिपेट करणार, तरच आपल्याला ब्रेड बटर मिळणार. मी सगळं खूपच सोपं सापं बोललं, तुमच्या लेवलच्या खूपच खाली बोललो, त्याबद्दल सगळ्या मोठ्या लोकांची माफी. धन्यवाद. थँक्यू. माझं नाव टाकल्याबद्दल मी आभारी आहे.
नाही, खूप छान होतं सर.
हो हो, थँक्यू.
थँक्यू सर.
I just wanted to say that Lalit is still there.
नाही ते हिंदी
Yeah.
आली असेल. हिंदीचा त्रास झाला असेल तिला. तिला खूप काम आहे ना दुसरीकडे. So it's okay.
Many years ago, when I was a resident, I had seen a child with chronic diarrhea, and that cause was HIV. So immunodeficiencies can be one of the cause, but of course that was many years ago.
एक एक काहीतरी आठवण सांगतो. दिल्लीला कॉन्फरन्समध्ये आहे, पेडिकॉनमध्ये मोठं डायरियाचं सगळं भाषण वगैरे झालंय. आणि मग मी ही गोष्ट सांगितली तर मेहरबान सिंग स्टेजवर उठून आले मला मिटिंग मारली. तू कहाँ से लाता है ये सब, तू आगे कहा नहीं. बरं असं ठीक आहे. मेहरबान सिंगची अजून एक गोष्ट सांगतो. डॉक्टर मेहरबान सिंग काबूलला गेले होते इन्स्टिट्यूट ऑफ चाइल्ड हेल्थ हेड म्हणून. तर त्यांनी एक प्रयोग केला. 400 मिझल्सच्या मुलांना त्यांनी पॅरासिटामॉल दिलंच नाही ऍडमिटेड मुलांना. आणि 400 देऊ दिलं. आणि त्यांना लक्षात आलं की ज्यांना पॅरासिटामॉल दिलं नाही ते लवकर बरे झाले, ते लवकर डिस्चार्ज झाले. सो पॅरासिटामॉल वॉज द कल्प्रिट which prolonged the illness, delayed recovery. So let's take a lesson. Thank you.
Now, our next speaker is Dr. Anjali Gokarna, madam. She is senior pediatrician from Vasai. And I request madam to go ahead with the Palghar epidemiology.
एक सेकंद हा. जगदीश अलकाय, तुम्ही मलेरिया मधला डायरिया सांगा की नाही, किंवा अजून काय काय तुमच्याकडले विशेष. अलका अंजली सांगेल तोपर्यंत विचार करा मग सांगा. सांग अंजली.
Okay. Just now they spoke about vomiting and diarrhea. So I want to say that last month in our hospital, amongst the admissions, the maximum number of admissions were for acute diarrhea. That was one. And I want to tell Raksha that the commonest problem we meet in OPD is constipation in various forms. So both these illnesses are quite common. And I took a inventory of what we have seen hospitalized patients in the last 1 month. And we have seen one patient of enteric fever amongst all the admissions that we had. Loose motions, vomiting, like I said, was the maximum. They were 12 patients. Febrile seizure was the second commonest problem. And somehow respiratory tract infections were just 2 who were hospitalized. And even in OPD, I saw a lot of patients with loose motions and vomiting rather than with respiratory infections. And one patient hospitalized was for UTI. Amongst the newborns who were admitted, one child was with hyperbilirubinemia and one was with dehydration fever. So this was what was commonly seen, and like Hemant has requested, Alka and Jagdish, Suryakant, if they are there, please tell us what you have seen commonly.
एक सांगतो काय, कॉन्स्टिपेशन इज सो कॉमन ना, ती आपल्या कॉन्स्टिट्यूशन मध्येच टाकली पाहिजे. माय पॅशन कॉन्स्टिपेशन.
Then we have to tell Pappu. We have to tell Pappu to take the constitution and tell about constipation. Yeah. So, yeah. Suryakant.
Anjali, what you have said, a similar picture we are seeing, but of late, in the last month, I've
Unmute
you are muted. Unmute kara, Suryakant. We can't hear you. I think now तुम्ही unmute.
नाही परमिशन दिलेली आहे.
Okay. Now it is unmuted.
Yeah.
So what I have seen 3 children between the age group of 3 to 5 years. Those were treated outside with fever and vomiting. And I thought that the patient must be having septicemia or they were complicated and they had symptoms and signs of subacute intestinal obstruction. And when the investigations were done, they were matching with subacute intestinal obstruction. With the routine treatment and keeping them nil by mouth for 1 day, 2 days, both of them improved with routine antibiotics like ceftriaxone, taxim, and injectable amikacin. Unfortunately, parents were not able to continue the treatment and they took a discharge, and I think they must have gone to Balsad or Vinova Bhave. So I don't know the
Follow-up.
real cause, whether they were complication of enteric fever or they were complication of some viral infection, but not typical case presentation like enteric fever or gastroenteritis. And then few cases of OPD basis as well as indoor also. Gastroenteritis is quite common, but they don't require higher antibiotics. I don't give antibiotics in OPD at least. I avoid. Till 5 days I wait. And most of them by third or fourth day, their diarrhea starts resolving and they do well. And another, Lalit is not there. I wanted to ask Lalit, it's a bad practice we have set in, I think, as soon as
Lalit is
diarrhea
there.
starts. Lalit,
Lalit
as
is
soon as
there.
if Lalit is there, whether it is right or wrong, I don't know.
Dr.
After
Neelam
diarrhea,
is also there.
many of our pediatricians suddenly switch over to simil products, and unfortunately, they are continued for months together. I have seen a patients taking simil products for 6 months, 7 months. So, what is your take on that? Because I think it is a misuse and unnecessary. Parents are paying a lot of money also, which is not required. So, how to tell
Yeah,
our
I
pediatricians and
think I appreciate. Yeah, I appreciate what you're saying. So basically, what we need to understand is about the lactose intolerance. Majority of the case, lactose intolerance is secondary and not primary. Majority of the cases, lactose intolerance is transient and not permanent. Having said that, Asians have lactose intolerance, but by the time they get it, they are not in the childhood. They keep growing. If you know the curve, it goes like this. So it's the adults and adolescents and adults who see more of lactose intolerance than in babies. But I appreciate what he's saying, that it takes couple of weeks for the mucosa to regenerate. The mucosa will regenerate within 3 to 6 weeks, depending on the degree of damage done to the mucosa. So I see no reason why it should be continued beyond 3 weeks, 4 weeks, something like that. So I endorse what he's saying, and it's what he's saying that Cheche Maine Literate, there is a point. And I also I don't like to criticize. That's the first thing I say. But in general, when I see patients like right now, as I talk to you, I'm sitting in Guwahati and I've seen like 30 patients already. So I do a clinic here once in 6 weeks. So I see very often that they milk is stopped if they are constipated. Now I can't keep criticizing and saying, but I don't see any logic. But these things we keep doing, and it's like a paradigm shift means like you do things because your mother did it and her mother did it, so we keep doing it, but nobody question why you did it, should I change? So that is called like a paradigm shift. So because my boss did it, I did it, like that. So well taken comment.
thank you, madam.
Yeah, Dr. Hemant. Unmute yourself, please.
नाही, आपलं काम चांगलं नाही. आपलं म्हणजे नॉट पसंत. वी डू नॉट राईट. आपण योग्य प्रिस्क्रिप्शन लिहित नाही. हे 1 10 ओनली किंवा जे काय तुमचं 7 days ओनली असं. अजून चांगली एक कल्पना आहे की तुम्ही आपण एक छोटं कागद द्या अँटीबायोटिक सोबत. तारीखच्या पुढे 1 2 3 खुणा करा. 3 डोस असेल तर 27 खुणा दाखवा किंवा 12 खुणा दाखवा. हे छोटा कागद द्या ना त्यांना. एक टिक मार्क करायला शिकले ना तर आपलं खूप सुधारणा होऊन जाईल. आणि ते नवीन शिकतील टिक मार्क करायला पण. झालं.
Yeah. Dr. Lalit, are you there? I think he's there on the list, but yeah. Also, I'd like to invite Dr. Bhadbade. Is Alka or Jagdish there? Would they like to say what they are seeing in their part of the Palghar district? Alka?
I think sir also left.
Yeah. Alka, you'd like to unmute and say what you all are seeing in
Tell your 50 experience of 50 years. Tell malaria in pregnancy also.
I request Dr. Yeah. Yeah, Jagdish, what have you been seeing in the past last 1 month?
Mainly virals. Viral diarrhea presenting with high-grade fever, vomiting followed by loose motions. Manage conservatively only with ORS, zinc, and probiotics and antibiotics. No antibiotics.
Good. Very
We
good.
had a couple of patients who these viral infections were treated by general practitioners with doses of mefenamic acid, and they came to us with persistent vomiting, and then we found out that it was drug induced hepatitis. So drug induced hepatitis due to mefenamic acid is pretty common, and so we have to educate our general practitioners not to use mefenamic acid so much because they go unnoticed. And I had one patient with fever continuing with vomiting, and we found nothing, absolutely nothing on investigation, but raised enzymes, liver enzymes, and viral markers were negative. And so we treated him conservatively, and it took 1 week, and he recovered. We had one child with very high doses of mefenamic acid being given, went into nephritis also, and we had to refer this child to Vaishali. And then she was thinking of doing dialysis for that child. So mefenamic acid has to be stopped. And paracetamol also in reasonable doses. So these patients need to be managed conservatively. I had 2 or 3 patients of meningitis, one viral meningoencephalitis and one TB meningitis in a 3-month-old child at Vedanta. And one case of pyogenic meningitis, 14 years old, treated only with ceftriaxone, recovered very well. No other higher antibiotics. That's what we are seeing.
Thank you so much. I'd like to invite Dr. Sylvia D'Souza, who is a pediatric cardiologist in Vasai Virar Belt. Sylvia, please, your experience.
Currently, I'm being
Sylvia, your voice is breaking, I think.
Unmute nahi केलं त्यांनी. She's on the other way.
Sylvia, your voice is breaking.
better.
No.
Hello?
Yeah, tell me.
Yeah. So in the few weeks, we have seen 2 cases of Kawasaki disease, that too in a younger age group. One child was 4 months old, which was in an Ankur hospital, and one child was 1 year, 1 month old, which was seen in Vikas. So normally Kawasaki we see in winters or early springs. So normally this time the but this time it will back to back case. We was
No, Sylvia, your voice is still quite. Your voice is breaking.
Ask her to use another instrument or close and come back.
Sylvia, you were saying you saw 2 cases of Kawasaki disease, one who was 19 months old and one who was 4 months old, one in Virar, one in Vasai.
Ma'am, she is out.
Okay. Yeah, so the case who was from Vasai was a 19-month-old child who was admitted with us and with high fever for 10 days and came with no fever, no cough, cold, and just a very red lips and very red tongue, and was receiving antibiotics outside. We hospitalized, and we thought of streptococcal toxic syndrome, and we started on clindamycin. But next day we thought of Kawasaki. There was no rash, there were no lymph nodes palpable, no liver spleen, there was no peeling of the skin. And next day, Sylvia saw and she says there is dilatation. The platelet count of this child was high. There was anemia. The ESR was 70. The CRP was high. And then the platelet count was 4 lakhs. And with the dilatation of coronaries, we started this child on 2 grams per kg of IVIG, and the child showed good response. Followed up with Dr. Sylvia, a couple of days later, and now is doing well. So just wanted to present, this child had very severe red lips, and then we were still wondering whether we were on the right track. And lo and behold, after 5 days, this child started getting peeling of skin around the toes and fingers, and the lips were cracking. So, some of the signs did come up later. So we saw this child of Kawasaki disease, and then Sylvia said that she saw a 4-month-old child at Palghar, at Virar. So,
Hello,
yes,
ma'am, am I
yeah,
audible?
Yes, yes.
yeah, Sylvia.
Yes,
So
yes. So, yeah, the first case you have already said. The second which we saw was a 4-month-old, which was seen
Yeah.
at Ankur Hospital. So, even this child presented with irritability, high-grade fever for 1 week, no other associated symptom or no other focus, high CRP. When echo was done to rule out Kawasaki disease, coronaries were significantly dilated with a Z-score of plus 3.5. Responded very well to a single dose of IVIG and aspirin, and both these kids are on follow-up and showing good progress.
Fantastic. Very
Anjali,
nice.
did you give aspirin too?
Yes.
Sir, yes, sir. Aspirin
Both
is given in
cases.
a higher dose. Yes. See the dose. They say that you can go up to 80 to 100 mg, but we don't go to this high. We normally keep it around 50 mg per kg per day in 4 divided doses for the first 3 to 5 days till the fever settles. Once the fever settles, we come to a dose of 3 to 5 mg per kg per day, which can be a OD dose or a PD dose.
For how long?
Sir, this depends upon how much the coronary dilatation is, but the studies and the trials conducted have shown it should be minimum for 6 weeks to 3 months, even if there was slight dilatation, because that is the time it takes for the inflammation to settle down. And even if the Z-score is less, we gradually continue this dose and then slowly taper and stop. But there are patients of mine which I have been giving aspirin in a small dose of 3 mg per kg per day, and has been going on for more than 2 years, because that coronaries, there were aneurysms at the time of diagnosis, and gradually it has come down. So we keep them on a follow-up. We do coronary CT angio for these patients to document the size of the aneurysms, and we keep that aspirin going in a small dose.
So, any case of Kawasaki where you get high Z scores with dilatation, when would you advise repeat to the echo?
Normally we in other there are acute, subacute, and phase. Acute and subacute phase, the aneurysm can develop. So we call this the 7 days of diagnosis, 15 days of diagnosis, to see that the coronaries size has started decreasing, or whether the development of any.
No, Sylvia, your voice is breaking.
So log out and come back.
Anjali, next meeting I would like to. Hello.
Yeah.
Next meeting, I would like to present, one of my residents will present a case of renal tubular acidosis,
Fantastic.
which we diagnosed, and the baby presented at the age of 2 years with extensive rickets and scurvy.
Arey, don't release everything now. Don't release everything now.
Yeah, and this has been worked up.
No, your case is taken up, but don't give away anything now.
सांगू दे का परत सांगेल ना आम्ही विसरतो डबल शिकायला लागेल ना
This was worked up very well, and we had taken opinion of Vaishali also. We have done the entire workup, and it is diagnosed on genetic studies as distal renal tubular acidosis.
Superb. We take it up next month.
40 वर्षानंतर का होईना पण जगदीशकडनं शिकायला मिळत आहे. प्रोफेसर जगदीशचा आपल्याला खूप फायदा होईल.
Yeah, and Vaishali has agreed to be expert for that case.
Superb. So I think you should.
मला एक डिफिकल्टी आहे वॉमिटिंग आजच्या सेशन बद्दल. सगळे मला सांगा, चिल्ड्रन कम विथ व्हायरल cough, cold, vomiting.
Correct.
By gastritis. What is the role of pantoprazole, प्रोटॉन पंप इनहिबिटर तुम्ही सगळे वापरतात का की काय?
डॉक्टर नीलम.
नाही ऑल नाही प्रायमरी तुम्ही तर सांगा ना. ती ट्रान्सप्लांट सांगायला तर ते ठीक आहे, पण आधी आपण तुम्ही सांगा ना प्रॅक्टिसिंग पिडियाट्रिशियन तुम्ही वापरता का पॅन्टोप्रेझॉल आणि व्हॉट एव्हर?
Bigger children, more than 10 years or so.
सगळ्यांना एव्हरीबडी?
सगळ्यांना नाही.
मग बिलो 10 years नाही वापरत?
H2 blockers can be used. H2 blockers can be used.
अंजली?
In children who come after they have eaten out and specific epigastric tenderness, I use lansoprazole. So that's one.
साधे पोर होतात ना, वॉमिटिंग केलं ऍडमिट झालं?
नाही
करत. बरं.
H2 blockers can be used.
नाव सांग ना.
Ranitidine.
बॅन झाला रॅनिटिडिन.
सिरप फॉर्म
अवेलेबल आहे सर, अवेलेबल
आहे सिरप फॉर्म मध्ये सुद्धा अवेलेबल आहे.
अवेलेबल आहे.
बरोबर. ऍज अ नो रॅनिटिडिन वर बॅन आलाय. ठीक आहे.
नाही
बरोबर ठीक. पण नॉट इंजेक्टेबल ना?
नाही ओरल मिळतं.
Sometimes we use injectable ranitidine.
पॅन्टोप्रेझॉल नाही वापरत? नाही. बरं.
So Dr. Manveen is also online. I want to also declare here that on this Saturday in our anemia OPD in Dahanu, sickle cell anemia, along with that, we are also going to do a surgical diagnostic camp as well as a echocardiography camp, because a lot of these patients also have surgical problems which is incidental, and as a screening procedure they need to have echocardiography. So Dr. Manveen and Dr. Shalil have kindly consented to come to Dahanu. So welcoming everyone to participate in this. Dr. Sunil Birhade has agreed, and Dr. Alka Bhadbade, myself, Dr. Manveen, Dr. Shalil will be there, and we welcome everyone else who are eager to join us.
Does Manveen do cranial Dopplers also for sickle cell patients?
No, we can't do cranial Doppler on the machine we are bringing there. I don't know about Manveen.
Yes, ma'am.
I think that's yeah.
So cranial Dopplers, we don't do actually.
Radiologist.
From Sion Hospital, when I was working under Dr. Mamta Manglani, we used to refer them to radiologists specifically to record those velocities in sickle patients.
Because that is required actually. Anjali, a lot of your sickles, we need to follow them up with 2D Dopplers. Cranial Dopplers.
So Jagdish, all these patients are taken to Borivali. Dr. Gala at Borivali does that for them. It's done free of cost. So all the sickle cell patients who are registered with us, they go to Borivali. From there, they go to Dr. Gala, and it's done there.
So all your patients at Dahanu OPD are subjected to cranial Doppler, you are saying?
Yes. All about 3 years are, about 2 years are subjected to cranial Doppler. Okay. Up to 16 years, once a year. Okay. And anyone who is found to have 200 or more of resistance index, they follow them up. And that's the whole procedure.
No, the cranial Doppler is mainly only to, as a guide for transfusions, yeah.
Yeah.
Yeah. To reduce.
So these are the patients who are then followed up at Borivali Center.
If the scores are high at Borivali.
Clarence can tell us something. Clarence? Dr. Badshah Khan can guide us. His experience of all these days. Dr. Badshah Khan from Wokat. I think we can call it a day.
Yes. So, Anuradha, with that, I have finished with epidemiology. Dr. Jayashree or Anuradha would like to say something?
मी काहीतरी सांगतो ना, 1 minute.
बोला ना.
I had a chance to meet the Mahila Bal Kalyan officer of Palghar Jilla Parishad. And I was amazed with his enthusiasm. He said, Doctor, how much will we talk? Let's do. So on Thursday at 5 p.m., they had asked me to come and talk to supervisors. I said, talking to supervisors won't help. Let's talk to all the Anganwadi workers. So that everybody, he said, how will you talk to 2,500 and their 2,500 assistants? I said, Zoom. And luckily, so Thursday 5 p.m. I met him. Both of us said yes. And thanks to fantastic leadership of Anuradha, Jayashri, and Anjali on Chana and all backup. Monday to Saturday, daily 45 minutes, we taught them childcare. Average 400 people were on Zoom, between 200 to 400, and 200 were on YouTube. So 500 to 600 people learned every day for 6 days, 45 minutes a day in Marathi, and all in story format and poems and fun. And one lady came today to thank me. She came from far away. I don't know the place where, beyond Dahan or somewhere, to say, just to say we had a nice time. So we try to go to the masses, and that's it. Thank you.
IAP की बात community के साथ. That's what we are doing. After this process, I would like the office bearers to stay back.
After we close, right?
Yeah.
Thank you, Baraka. Anuradha, एवढं काम करते बिचारी.
Thank you very much. Thank you very much, Dr. Neelam. I think Dr. Neelam has left, and thank you so much, Dr. Lalit. On behalf of Palghar Academy of Pediatrics, I'd like to.
No, I didn't leave. Thank you, thank you, thank you.
Thank you, Neelam. Your
Neelam,
presence
thank
was much appreciated. All your comments were excellent, and they can be
Very
put into
sweet.
daily practice. And wishing you good luck in your endeavor
Yes,
this year.
and thank you. And I heard how women are doing great job everywhere. Mumbai is one place where we should take example in the history of IAP. 9 out of the 11 executives were women, and they said that it was the year. In fact, Rakesh Chokani was telling that when she was the secretary, there was highest number of work done. So actually, it's so nice to see that women not only who've been doing at the home front, they're equally capable of doing at the professional front. And we need to be together, support each other, and mentor each other. The youngsters, where what mistakes we did, we need to teach each other and appreciate other women who are doing great.
Dr.
Thank you,
Neelam,
thank you.
for the past 3 years, ever since the inception of Palghar Academy, we've had lady presidents. The first lady president for continuous 5 years was Dr. Archana Joshi. For 2 years was myself.
Wow.
And this year and henceforth will be Dr. Jayashri Deshpande. And we have an all-women's team this year and last year as well.
So I'm so proud of you. And Archana loves me.
And it is by the women, for the women, and of the women.
Yeah, we forgot Dr. Manveen had joined. When did Dr. Manveen speak? Did Dr. Manveen?
That's lovely.
Yeah, she was telling about cranial Dopplers.
Yeah, Manveen,
Yes,
where is she?
She was there online.
नहीं मैम आता नहीं है.
Leave
Chalo,
झाल्या
give my regards to the entire team, and just that's all I have to say. Congratulations to the entire team.
All the best.
Yeah.
All the best, Neelam.
Thank you.
We'll work for you.
Blessings from seniors and love from
Yes.
colleagues. Thank you so much.
Yeah, I think with this we can wind up, Anuradha. Thanking everyone who joined today. Thank you, Lalit and Raksha, our speakers, and thank you all those who contributed. And
thanks to Badabades,
Tupkar sir.
Alka,
thanks to
and
Dr.
Surekant.
Tupkar, our observer. Thanks to Anuradha for having got all of this together. And thanks to all our attendees today who have stayed on. And thank you, Hemant and Archana, as always. You're always a guiding force. So,
Please some time. Office
And
bearers.
thanks to Clarence, who has just left.
and thanks to Pallavi for conducting this webinar flawlessly. Thank you, and thank you, everyone.